Are we ready to go in the back? Okay, great. Hi, everyone. Thank you for joining us, all you in-person folks and our virtual folks online. My name is Ashley Hayden-Peaches, and I'm the Community Health Worker Manager at Samuel U. Rodgers Health Center. I have the honor today of introducing our amazing speakers. Before we get started, I wanted to take a minute just to name and thank all of the sponsors for today. HRSA, Samuel U. Rodgers Health Center, OASH, the Health Forward Foundation, Mark, and the REACH Foundation. Thank you to them for helping us get this all together. Just a few housekeeping items before we get started. If you need access to Wi-Fi, the Wi-Fi name and password is in the back on the little board there. Handouts for each of the sessions is also on the table in the back if you need those. The restrooms are down the far hall all the way to the end. And if you need snacks and beverages, they will be available throughout the day, so please refresh yourself as needed. We are so happy to see everyone in person today, so please use your own discretion when choosing to mask and social distance. Our first speaker loves all things CHW. Bob Tice is the CEO of Samuel U. Rodgers Health Center, where he has worked for 15 years and has been a huge supporter of the CHW program. Please welcome Bob Tice.
So I didn't write anything down, but I'm just going to talk from the heart. I love community health workers. You guys connect people to services everywhere, services that they may not have even known existed. And so that's the coolest thing. Get to know each other, get to know what each organization does. Sam Rodgers provides high quality, compassionate, and affordable healthcare, transportation, language. We help people sign up for Medicaid and the Affordable Care Act. So many things that people don't know that they need and or want. You guys help connect. You make it easier. Community health workers, I do love community health workers so much. You are my favorite people. And so the people in the room, the people on the video, wow. All I know is you help connect people to everything. And so I'm not gonna say too much more. I'm not gonna be up here forever, but what you do is important, and learn from each other because it's so important. I think I'm gonna stop there, but I get up and I talk to Ashley and her group, and I'm just wowed by everything they do. But that's all I'm gonna say today. But I love community health workers. I love everything you do. Learn and learn how to take care of yourselves, because if you can't take care of yourselves, you can't take care of others. So thank you very much.
Thank you, Bob. So our keynote session today is Navigating Ethical Issues in the New Normal, presented by Dr. Jay Memmott. He's the director of the Graduate Social Work Program at Park University. Dr. Memmott brings us a wealth of knowledge and an important discussion on how health workers have been affected by COVID-19 and its lasting impacts. So I would like to welcome Dr. Memmott.
Are you okay with me taking my mask off? Okay. All right, well, my name's Jay Memmott, and I've been around the block. I do want to say, before I get started, that it's an honor to speak to you as a group and to speak at the Kauffman Center. This is a beautiful facility, and I know that they're also streaming some of the presentations today. So without further ado, I'd like to talk a bit, as the title says here, Navigating Ethical Issues in the New Normal. And I wanted to start off, as an academic, one of the things I emphasize with my students and certainly I think I had this happen to me when I was a student, I've been a student a number of times, is to define terms. And so we talk about the new normal. And, what is normal? What does that mean? And so if you could go to the next slide, okay, and then there are 4 different definitions, at least 4 different definitions of normal or normality. So if you could go to the next slide, please. One of these is the absence of disease or pathology. So we're all familiar with that. Either you're sick or you're not sick. That's one sense of being normal. Another one is what's called the Utopian Definition, and that's where we think in terms of optimal functioning. And so we talk about self-actualization would be kind of the ultimate form of normal, in fact, maybe beyond normal. The one that a lot of people think of as a definition of normal is a statistical definition. And I don't know, how many of you took statistics at some point in your education? Are you still having nightmares about that? Yeah. I actually have taught statistics, so I'm one of those people that inflict pain on others. We talk about the median, we talk about the average, we talk about the mode. I mean, those are statistical terms, but that's another way of thinking about it. It's sort of like the whole idea if it's like lemmings. If lemmings are going off the cliff, then I might as well go off the cliff too. I mean, everybody's doing it, so that's a sense of normal in numbers. Then there's another sense of normal, and we think of this in terms of like child development or human development, in terms of a process. And this can be lifelong, or it may be seen in terms of stages or whatever. But these are some of the ways we think about normality. But there's this term, the new normal. And so the next slide. I have to remember to do that. So the new normal, that phrase is actually what's called an oxymoron. And I have to warn you, my undergraduate degree was in English, so I'm going to throw, metaphors at you and that type of thing. But an oxymoron is really just a figure of speech, and it's where you take contradictory terms and put them next to each other. So new normal, or small crowd, or old news, or open secret. These are all examples of phrases that are called oxymorons. But if you could go to the next slide, the term new normal is in some ways problematic. It implies a sense of permanence that makes some people quite uncomfortable. I mean, how do you feel about at least the idea of having to wear a mask for the rest of your life when you're out in public? I mean, now, obviously, I think we're headed out of that. I hope we are. I mean, I'm not real happy with some of the news coming out of the White House. You may have seen this in the news this week, where they're predicting that this fall we may see 100 million people get infected. And that's just an estimate. And then, of course, the other thing that was in the news this week is that we've reached our milestone of 100 million people have died from COVID-related illnesses. And it's been estimated that 300,000 of those cases were preventable, which is what I think we're all about, is trying to prevent things before they happen. But just to take just a little kind of side tour here, maybe we need to come up with a new phrase, new normal. And we can do that by taking synonyms for new and normal and putting them side by side. So if you could do the next slide, please. So these are just synonyms for new and normal, and you can do any combination. Meaning like original order or innovative average, or, I mean, it's kind of nonsense terms. If you could go to the next slide, please. So we have phrases like strange routine and unusual standard and unfamiliar order. And, to be honest with you, new normal sounds better, but I still don't like that. I don't like that phrase. I don't like the idea of new normal. Now, there have been if you go to the next slide, there's been efforts to kind of look into and peer into the future to see what this is going to be like. What are our lives going to be like after this pandemic? And we know that societies do come out of pandemics. I mean, for example, the oft-cited example of a comparison to this pandemic is the pandemic in 1918, 1917, the Spanish flu, which actually killed more people. And I had the opportunity one time to talk to my wife's grandparents who had just gotten married that year when the Spanish flu hit, and they lived in Topeka, Kansas, and they talked about what that experience was like. I don't know if any of you know, but do you know where the Spanish flu, where we believe it started? Fort Riley, Kansas. Burning piles of manure. And what happened there is that if you look at public health and disease vectors and that type of thing, troops at Fort Riley were then shipped overseas for World War I. And so there was a transmission of the disease and then troops coming back, and there were several waves, global waves, of that pandemic. The unfortunate thing, of course, back in 1918 is we didn't have any way of vaccinating people. We didn't have any way of immunizing people. We do now. But what's interesting, of course, is we have this whole controversy of vaxxers versus anti-vaxxers. And even people in public health, working in hospitals, some folks take a position against vaccinations. Now, personally, that doesn't make a lot of sense to me, but I have talked to people who are opposed to vaccinations, so at least I understand where they're coming from. I just don't agree with it. So there was a study done by the Pew Research Center and the Elon University Imagining the Internet Future, and this was a survey focused more on technology than anything else. And I'm not going to read the whole slide to you, but they talked to a lot of experts in a very short period of time in 2020. And so they ended up getting responses from 915 people. And in some cases, the individuals only answered one question. In other cases, they answered all of them. And at the end of this presentation, or if you look in the slide deck, I think you have copies. There's a reference to this study, and you can actually find it. It's a pretty hefty document. But next slide. These are the major themes. And they're in some ways sobering, in some ways encouraging. And I don't think there's any surprises here. But they found that most experts believe that there would be a worsening of economic inequality, which obviously has something to do with our values and ethics. Another one is new reforms for racial justice and social equity. But we also can see, if you pay any attention to the news, that there are social forces out there that seem to be pushing for social inequality, supporting discrimination, supporting oppression of people. And as a social worker, those are things that I oppose, not just personally, but professionally. And I think a lot of other people do as well. If not from a professional standpoint, from a personal standpoint. Another one is an obvious thing, technology enhancements. And we've seen that just in the last couple of years with Zoom and Microsoft Teams and all kinds of virtual ways of communicating and meeting. And I think we're all tired of that. And I hope that we see less of it and more face-to-face in person. But that may not necessarily be the case. But what we're hearing is that there are going to be further enhancements of technology that will make it even more realistic to meet virtually, and other communication as well. Then there's what goes with that is the power of big technology. And so Facebook, for example, Facebook changed its name, and what did they change their name to? Metaverse, and Meta, yes. And we've got Google, and we've got all of these other platforms, and some of them people are abusing. We can use, I remember hearing an expert many years ago being interviewed in the news, and this individual was saying that with every technological advance, there are going to be people that will figure out ways to abuse it, to take advantage of other people, to cause harm, which again plays into this theme of ethics. Positive thing is enhanced quality of life. For not just individuals, but families, for workers. And then the last one is probably the most disturbing, and that is that there will be continued and amplified, I want to emphasize, amplified spread of misinformation. I mean, I don't know about you, but I have become very, in the sense of being critical thinking, very critical of my consumption of the news. I want to know where this information is coming from. Another thing that is a trend that I've noticed, and this is even, I see this even with National Public Radio, is that we'll have someone interview someone else that's on their staff who's an expert, but what they're doing is they're expressing their opinions. They're not facts, they're opinions. And that there's a place for that. But what happened to the good old days when the truth was reported? Now, I realize that that's not always been the case either, that there's always been some bias. But if you look at the training of professional journalists, for example, I think there's been an erosion in journalism in terms of communicating and checking sources and making sure that the facts are straight, rather than talking to somebody who is getting paid to put out a particular line or a particular story. So, and there's other things with worsening social and economic inequality. Next slide. I mean, you look at the news. I mean, it can be very discouraging. We have things like climate change and the war in Ukraine. And I see that Biden is sending troops to Somalia. Gender inequality. We have LGBTQI plus issues and state legislation and legislators, at least in my opinion, promoting inequality. Just the availability of health care, many of you deal with that. And I was talking with the folks here that are healthcare navigators and talking about just the waiting for eligibility. What was it, 114 days, 116 days, something like that? Yeah. Bullying, I mean, that's still an issue. And it's not just in the schools now. And then, of course, we have crime. How many shootings did we have this week? And you know, again, I don't mean to upset or insult anyone. I'm expressing my views, but I don't understand. I mean, I understand Fourth Amendment rights and Second Amendment rights and all those types of things in terms of having a weapon. But I don't understand why somebody needs a semi-automatic rifle, for example, to go hunting. I mean, where's the sport in that? But that's my view. We have poverty, and we have overpopulation. We have mental health issues. And we have issues of immigration, which is a global issue. I mean, we're seeing immigrants coming into countries in Europe from Ukraine. But we've seen waves of people coming from different places. Next slide. So there are different levels of things. We can talk about micro issues in ethics. We can talk about meso, kind of group level, macro, national, international policy issues. But is that all there is? So next slide. Looking at COVID, how do I balance my personal care of my clients, service users, service participants, whatever term we use for the people that we serve, and my concern about getting infected myself? How many of you have had some concern about that in your jobs? Okay. Next slide. Another one related to this is, suppose I find that I have some symptoms and think that I may have been exposed to COVID or anything else, really. Should I disclose my symptoms to my employer and self-quarantine, or do I continue working, risking the health of those around me until I test positive? Now, my understanding is there are clear guidelines about what you're supposed to do in that situation, but not everybody follows guidelines because of the situations that they may find themselves in economically. Maybe they can't afford to do that. I think one of the big reasons why so many parents were pushing their kids back into school when maybe that wasn't such a good idea from a public health perspective is because they couldn't stay home to take care of their kids. They didn't have the money to pay for childcare. Oh my gosh, what does childcare cost for one kid? I mean, people just can't do it. So people are being put in these terrible situations where they have to make decisions, which is really cuts to the heart of ethics and ethical issues. Okay, next slide. But there are other issues. So have these issues gone away? Next slide. Now this is originally framed in a religious context, and I'm not trying to get religious on you. But the 7 deadly sins. And just tell you quickly that a monk, a 4th century monk named Aeg Ponticus, came up with a list originally of 8 deadly sins. In the Catholic Church, they would call them mortal sins. Sins that if you don't repent, if you engage in these behaviors, you lose your soul. It kills your soul. It kills you spiritually. So we have then, what happened over time is that this list was pared down to 7. And some things were taken out. For example, the man who became Pope Gregory I rearranged the list, taking out sloth and adding envy. And then instead of giving pride its own place, he basically said it was kind of the umbrella sin of all the others. Then over time, we've come up with this list of the 7 deadly sins. But how many of these are still issues today, irrespective of a religious context? I think they all are. I mean, it's part of human nature. Next slide. When we talk about values and ethics, of course, there are these things that tend to be tied more to our jobs and our profession or professions. So in my field in social work, having been a provider of mental health and addiction treatment, behavioral health services for many years, there's the whole issue of alternative treatment methods. Is it ethical to offer a treatment to someone that hasn't been tested? We saw that a few years back with the Ebola outbreak in Africa and the development of really experimental vaccines. It turned out that they were reasonably effective, but they were still used experimentally. But it was in a drastic situation, So the idea was that, well, because of the emergent nature of the situation, it was okay to use these experimental vaccines. The question I have is, were people told or informed that these were experimental? Boundary violations. We were talking at the table again earlier, that it depends on the length of time that you have contact with your clients. If you have a long-term relationship, there's more of a likelihood there's going to be boundary issues. But also if you live in a rural community versus an urban community. But I can tell you, I worked in a corporation and there were boundary issues within a corporation. I mean, in some ways, even though you think of corporations as being kind of a city-urban issue, that there were still boundary issues because of the nature of that small network and clustering of people. Things like confidentiality, discrimination in treatment, making false and misleading statements. I mean, there's a litany here. Next slide. Other issues, billing. What do you do if you close a practice, or, you know, if you're in an agency and you close your agency, or if you're in private practice, or whatever. Kickbacks, bartering, record keeping. How many of you have to keep records? What happens if you don't? Not a pleasant thought. Drug and alcohol use, not just among our clients, but also maybe our colleagues. Any of you had to work with an impaired colleague? Yeah. Duty to warn, interprofessional issues, supervision. Okay, next slide. And then there's a couple of others that really would be more in the realm of, I'd say, mental health, forensic evaluation, group therapy. And the big issue in group therapy, of course, is that there's no such thing as confidentiality. People are going to talk about what was said in the group, as much as you might warn them not to. Next slide. So I want to take just a step back here. Next slide. What are values? This is going to be kind of a quick review. There are ideas about how the world should be. Hear that, should? And how people should behave. Now that is problematic right then and there, because who is going to determine this? Who's going to say what people should or shouldn't do? Who has the right to do that? Who has the power to do that? You could also think of values as the beliefs about what we value or what we think is important. Next slide. So what is ethics? You can get real fancy and academic and talk about it as a branch of philosophy. It's a way of thinking about concepts of right and wrong and systems of ideas. The term ethics is derived from the Greek word ethikos, and it's derived from the word ithikos, and ethos, which means habit. Next slide. But simply put, ethics is simply the application of values in life. Just applying, the very practical day-to-day application of our values. Next slide. But what makes things complicated is that there are what are called value systems. Value systems are networks of interconnected ideas that create a kind of whole. And we think of those value systems as different ways of thinking about things. And I think we all recognize that there are lots of different value systems out there. Next slide. So the question is, why is ethical conduct difficult? And I wish I had more time to think about this and putting this presentation together this morning. But one of the reasons why I think it is difficult for people to conduct themselves ethically is because of the complexity in the world today. Things are not that simple. For example, I don't know, some of you have been around maybe as long as I have on this planet, and certainly if you watch old Westerns, there used to be these old Westerns that were, you know, the guy in the white hat and the guy in the black hat, and it was very clear, black and white, you know, good and evil, and who won at the end of the serial or the movie or the episode. It was always the good guy, the good person. Good wins over evil. But if you look at media, if you look at film, particularly Clint Eastwood would be an example of some of the films he's put together over the last 20 years, showing that there's a lot of gray in between and that things are not that simple. So that's one of the issues. And we can think of complexity in terms of the environment. We can think of it in terms of the different situations that we find ourselves in. The organizations that we're in some ways determine ethical outcomes and ethical conduct. Also, our intentions. And intentions are really hard to assess, to evaluate, even in ourselves, because sometimes we're very good at concealing things from ourselves and from others. Another one is just information. How much information do we have? And is that information accurate? And then the connections between all these things and our connections with people and things. But another one is that there are conflicting value systems. And part of that, too, is that as we are growing up in our families, the metaphor that I use is that we're like little sponges. We absorb what is around us. We soak up what is around us. And it isn't until we begin to develop, I think, a sense of self-awareness and consciousness that we may be put in situations where we have an opportunity to question what we were taught. And I think it's important that we do question what we have been taught, even if it is right, what we've been taught. Because we have to determine for ourselves what we believe, what we think, what we feel, and how we're going to conduct ourselves. Next slide. So there's another issue that has come to fore, and I think this is, from my perspective, in the last 20 to 30 years in this country, but I think this is a global phenomenon, is that there are these things called ideologies. And these are systems of ideas, and which form a basis primarily for economic and political theory and policy. You can think of it as a body of doctrine. You could also think of it as a set of political beliefs that characterize an individual or an organization. And common examples, as noted here, and there are lots of others. Capitalism is an ideology. Communism is an ideology. Socialism, which is supposedly a dirty word in America, is an ideology. Marxism, heaven forbid, is an ideology. Next slide. So these are the ones we think of: Republican, Democrat, Libertarian, Green Party, classic liberalism. The issue, the point I want to make is that I think that values and ethics have become political. Very, very political. And it is confusing the heck out of a lot of people. And I don't know if this is a deliberate thing that's going on in our society or what. And again, it's global. I mean, you read the news, these issues are the same in Europe, in Asia. We're seeing this even in the former Soviet Union, Russia, primarily through the news outlets talking about Ukraine. But I think it's an important point that values and ethics have become political. They have become politicized. And I don't know if that's a good thing or not. It concerns me. So if you could skip, please. So let's bring this around to professionalism. So we have this thing called professional values. Now, the thing I want to say is that we have ideas about, as professionals, about what should happen with the people that we serve. They should have access to resources. They should have the right to good health care, or at least access to good health care. We think that people are unique and they have worth. I mean, at least that's what we're told we're supposed to believe. That people have a right to self-determination, with some notable exceptions. For example, at my work in mental health, people don't have a right to kill themselves. People don't have a right to kill other people. Although I will tell you an interesting thing, just as an aside. I used to teach at the University of Oklahoma. And I, one year, decided to do these courses where incoming freshmen, you help them orient them and get them on the ground. And some universities, these are students that may be academically at risk. And I remember having a conversation with my class one semester about killing. And it floored me that some of my students in my class thought it was all right to kill somebody, unprovoked, that it was okay to kill somebody. That wasn't the way I was brought up. Now, I understand I'm coming across as an old guy that, grew up way back when things were different. And I get that it was different. But should it be that different? I'm not sure about that. So next slide. So these are the core values of social work, but I think they're common across most disciplines. Service, social justice, dignity and worth, importance of human relationships, integrity, competence. But I'll tell you, of all of these things, there is one that, it's implicit in the list, but it's not explicit. And that is caring. Caring for other people. Not me, but other people. Other people come first. I come second, third, fourth. And that's one of the problems we've seen with professionalism in this country and how it has become politicized. We have people who are saying, even though they're professionals and they may have professional ethics to guide them, that they're saying, I ain't gonna do that because I personally don't believe that, or it's not part of my value system, or it's against my religion, or it's against whatever. That's not how a profession works. And I think we've lost sight of that. That what you do as a professional is that you put yourself way, way back of the bus. And your client, the person that you're serving, whether it be an individual, a family, a group, a community, comes first. And it does not matter what I think or what I feel. My job is to serve. So if I'm a pharmacist and somebody comes in and they want the morning after pill, It's not my right to deny that person that, even though I may be adamantly opposed to the idea of abortion. That's what service, that's what professionalism is all about. Okay, next slide, please. So we have responsibilities as professionals to enact our values that are associated with our profession. And that is to, as noted here, to recognize and to explore our own values. This is a lifelong journey. I have spent most of my adult life becoming more conscious and aware of what's going on inside of me, and not everything has been pretty. Some of the things that I've had to deal with are things that I soaked up as a little kid growing up in a home with a dad who was bigoted, who was at times abusive, and having to try to work that toxin out of my system. Confronting biases, which can be very, very uncomfortable. And then gaining insight, how values beyond myself as a person help me begin to change what's inside and how that manifests outside. Also to recognize that there are going to be times when values will create barriers. And also being careful not to assume things. That just because values are similar does not mean that they are the same. Also, not assume valuelessness. One of the reasons why I think people get into ethical difficulty as professionals or as people in everyday life is that they do what I call context stripping. They strip away the context. They strip away the situation. And one of the things that social workers emphasize is the context, the environment. And in some cases, they're nested. In some cases, they're networked. But we have to pay attention to context. Okay, if you would skip. There are lots of value systems, but the one I'm going to talk about briefly here, and can somebody tell me how close I am to my time? 20 minutes. Okay, good. Okay. One philosophical approach to values and ethics is what's called the virtue approach. You're all familiar with it. It places emphasis on characteristics, attitudes, the disposition of a person. And I believe it enables us to act in ways that develop our potential, not just as individuals, but as collectives, in our families, in our communities, the different organizations and groups that we belong to and associate with. So examples of virtues, of course, would be things like honesty and courage, trustworthiness, integrity. So the idea here is that what is ethical is what develops these moral values within us and in our communities. So, next slide. Okay, so let's go back to these 7 deadly sins. There are what are called the 7 virtues that correspond with them. And this is very much part of this virtue approach. So, corresponding to lust is chastity, purity. And it's not just in the sexual sense, it's also in terms of just trying to be as pure and clean as we can be as human beings, uncluttered. unsoiled, untainted. Gluttony, temperance. Or, as noted on the far right column under what Aristotle and Plato would have said is moderation. Corresponding to greed is charity. Giving freely. Giving without the need to be recognized. Sloth. Instead of sloth, many people would associate with laziness. Being industrious, being diligent, paying attention, attending to one's responsibilities. And then wrath, of course, anger, patience, forgiveness, understanding. Envy, being kind. Just being aware. I mean, how many of us compare ourselves to other people and their situations? And I don't mean to speak for you, but I think a lot of folks do. You know, you drive down the road and you see somebody pass you by in a nicer car, or someone that drives by you in a vehicle that's not as nice. Or we see people in the grocery store, or we see people in film. We see people in our neighborhoods. I think it's human nature to make comparisons. But then what do we do with those comparisons in terms of the judgments that we make about ourselves and other people? And then the last one is pride, and that's humility. Years ago, right here in Kansas City, do any of you remember it was actually transactional analysis. It was a form of therapy. A guy named John O'Hearn was the guy that did the workshop, but the idea of the OK Corral, transactional analysis, parent, adult, child. We did an exercise, and that was that we were supposed to turn to the person next to us, a pairing exercise, tell them something that we were proud of, something that we had done that we felt was good. And then after we had shared back and forth, then we were supposed to then compliment each other for that thing. And then the speaker asked us to talk about how we felt when we received that compliment. And it was really revealing to me because, sort of like Bill and Ted, I didn't feel worthy. How many of us don't feel worthy? And it's because of this thing called, we're not supposed to feel pride. And that's confusing to people to sort that out. When is it okay to feel good about what you do, and when is it prideful? When is it excessive? When is it, to use a modern day term, narcissistic? Don't want to be narcissistic. And certainly, having humility, as Aristotle and Plato pointed out, takes courage. Okay, if you would skip to the next slide, please. Okay. So we have professional codes of ethics. Community health workers have a code of ethics, right? Are there other disciplines represented here? Nurses? You have a code of ethics, right? Physicians? Code of ethics. Hippocratic oath. Social workers have one. Psychologists have one. A variety of different disciplines have a code of ethics. In fact, today it's really kind of confusing. Another thing is, what is a profession versus an occupation? And one of the things I do, I spend time with my students trying to help them understand what is a profession. And there are problems being a profession, to be honest, but there are a lot of benefits. But a profession is simply a disciplined group of people who adhere to an established, codified set of ethical standards. It's written down how you should behave. And we agree as a group of people when we join that profession, that group, to abide by those rules, those guidelines. We also, as professionals, hold ourselves out to be accepted as possessing some kind of special knowledge, not special in the sense of prideful, but special in the sense of being able to provide a service to others, to serve others, that we have knowledge, skills, and the competency to do what we do well in helping others. This knowledge that we have and these skills is grounded in science, in evidence, which is another thing that's happened in our society globally, is that people have become suspicious of science. And part of that is because people who conduct science are being seen as part of the elite. And the elite are cast as those who are oppressing. Now, I will be the first to say that anybody in a position of privilege oppresses, whether we like that or not, whether we want to or not. It's just built into the structure of our society. And knowing that, we can do things to hopefully counter it. Another thing is that we are prepared and willing to apply our knowledge, our competency to serve others. Finally, although this doesn't happen all the time, we see it in the news periodically, is that the discipline, the organization that embodies the code, also disciplines members if they fail to abide by that code. Next slide, please. So, professional ethics are behavioral expectations, how we are supposed to behave. And as I mentioned early on, we can think of this in terms of the one-on-one, what we call microethics, interpersonal dealings. But we also think of it in terms of macroethics, large system organizational arrangements and values. And that's a problem too. What if we find ourselves in an organization where the organization's values or value system conflicts with our own? What do? The guy that was family therapist that I spoke to and got to know some many years ago, and we were talking about being part of organizations that were dysfunctional or had issues around values and that type of thing. And he used a family therapy term. He said, well, you can reframe yourself and reframe yourself and reframe yourself, but eventually what you end up doing in a really dysfunctional system is you reframe yourself right out of the system, which means you leave. You don't stick around. And sometimes that's what we have to do. Okay, if you could skip to, a minute here. Yeah. So I mentioned integrity, and someone put this together, this list of, I call virtues. But I think it's a very simple set of guidelines, and most codes of ethics embody these ideas of being honest, being congruent. In other words, walk the talk. Do as you say. Be consistent. Very important is obey the law. One of the things that happens when people get into ethical situations, and I might say again, just as an aside, it literally drives me nuts when people talk about ethical dilemmas, because not all ethical situations are dilemmas. It's pretty clear cut what you have to do. It's just that it's unpleasant sometimes to deal with it. So, but what people do is they look at their code of ethics when they're trying to make a decision about an ethical situation, but they forget to look at the law. Sometimes something may be unethical, but it's not illegal. And you want to be clear on what the law says, because sometimes the law tells you that there are things that you need to do that your code of ethics doesn't address, or your code of ethics tells you to do something different. You need to understand and identify, be clear on organizational values and priorities. If you're not aligned with the organization you're part of, you need to step out, as I say. You need to develop trust and respect with others. You know, I spent many, many years learning all these different models of working with people, systems of helping, techniques, all that stuff. And what it all comes down to is caring, respecting and caring for your client. You can be the most skilled helper on the planet, but if you don't care, the people you help will pick up on that very quickly, and they will not invest in you or the relationship. And then in that sense, you will be ineffective, and I think incompetent. You need to work as a team. And one of the things that many organizations, when they hire people today, are looking for is not just individuals who can work as a team, but individuals who are open to learning. And then creating a sense of commitment to people, colleagues, clients, the organization, the overall well-being of the community, society. And then being willing to discuss the ethical issues within that organization. One of the things that I would challenge all of you to do when you go back to work is to find out, what are the ethical guidelines in your organization? Does your organization conduct periodically some type of ethic audit? Do folks consciously look at what we're doing, and is it ethical? Are there things that maybe we need to do differently or do different things? And then value each other's differences, which can be hard to do sometimes. But to value each other's differences and seek solutions that are inclusive. Now, I have a lot of other things I can say, but I think I'm going to stop here and simply say that it's up to us to behave and conduct ourselves ethically. But we also, in walking the talk, need to serve as models, role models, if you will, for others. And as for myself, I would hope that at the end of my life, if there's anything that I have done, I've influenced others in a positive way. And the other thing is that I have learned more from the people that I have served than perhaps what they've learned from me. Thank you very much.
Thank you, Dr. Mehmet. Dr. Mehmet is having a follow-up session as one of our breakouts, so if you have any questions about this session, you can address them in that breakout session. Also, one other note, the table on the back is also available if you have any physical resources or handouts that you would like to share with the open group, so feel free to place your handouts and whatnot back there. Our next speaker is Florence Adegoke, as she is from the Community Health Worker Association of Missouri, and she's going to give us a brief overview of what they are working on. Welcome, Florence.
Good morning, everybody. So for Kansas City people, they're like, what? Florence, Community Health Worker Association of Missouri? She's right here in Casey with us. We're everywhere together. So yes, Florence Adegoke is my name. I work right here in the Casey metro area at University Health. And I am also a community health worker instructor with MCC, and I look around the room and everywhere I see familiar faces, and I look this way and I'm looking at my former boss in the MCC program, Dr. Manuel Solano. I see some of my students in the room, and I serve on the board of the Community Health Worker Association of Missouri, and not wanting to embarrass people, but there are also other members of the board. And if you don't mind, Suzanne and Trevor, please stand up so that they'll know that I'm not a lone ranger in the room. So Susan, go ahead and stand up. Susan, don't just clap, stand up. Yes, of course you're on the board. Yes, you are. We're in the meetings every day together. So, so you're an at-large member, aren't you? Yeah, you're an at-large. You forgot you're on the board, right? Oh, that's okay. Sorry. Okay, she's not here today. So Trevor Smith is also on the board. And so the Community Health Worker Association of Missouri, next slide, please, is the Association of Community Health Workers, Community Health Worker Instructors, employers, payers, and other interested individuals who work with community health workers across the state of Missouri. So anyone who is interested in community health work and outreach and wants to be involved with the community is welcome to join the Community Health Worker Association of Missouri. Next slide, please. So our vision is put into action by advocacy. So we advocate for the work of community health workers as a profession. We put out a lot of educational opportunities, and a lot of it also comes out through the Missouri Credentialing Board, because the Community Health Worker Association has a credentialing process for community health workers. So community health workers can be credentialed through the Missouri Credentialing Board. So there's a lot of education opportunities, and thanks to the Mid-America Regional Council and all of our curriculum providers, continuing education units, CEUs, are required, and for your credentialing and renewals, and those are the reasons why the educational opportunities are there and in place. Professional development workforce to help in developing community health workers' professionally are also put in place for community health workers who are members of the association. Why is this important? A lot of us know that a lot of people come into the profession as community health workers without prior experience. And I'm looking at around the room for some of my students. I had one of my students come into one of my classrooms recently to say when she was hired, her employer had to tell her that you have a lot of street lingo, but you don't have a lot of professional lingo. So we have to train you to talk, not like you talk on the streets, but now to talk like a professional. So there's a lot of professional development that the Community Health Worker Association of Missouri does. Next slide, please. So there are resources. If you ever go through the training program, one of the big inputs into that program is the training program requires you to do 60 hours. And if you ever take the course with Florence, you're gonna love her. 60 hours minus 1, she will send you back. 60 hours of service learning in which you go do resources. Why? Because as a community health worker, getting resources for your clients is what you do. You are not the resource, you are the bridge, you are the connector to the resource. So, helping community health workers identify and get resources and teach them how to navigate the community to get resources is one of the things that the Community Health Worker Association of Missouri helps you to do. They help them community health workers to also identify employment opportunities. While in training, we get people in the classroom who have employment opportunities to come advertise. In one of my trainings, I had someone who's sitting somewhere in this room come into my classroom and say, I want to hire community health workers. Before that class was over, 3 of my students had been hired and had started working. The greatest joy I had was that student came to class one day crying and said, this is the largest amount of money I have ever had in my bank account. And not only was the student crying, the other students were crying. I was crying too, crying for joy that here we are doing something and giving employment opportunities to people who would otherwise not have had it. Networking. As we have meetings, our plenary speaker just said, we're all happy we are out and about and we can meet and network again. Thank God for Zoom, but there's nothing like face-to-face. We can talk, and networking gives us opportunity to connect with one another, learn from one another, share one another's experiences, grow one another, grow our networks, and with that, that comes across. And our conferences have been virtual in the last 2 years, and we're hoping that next year we'll be able to have an in-person conference, and that as things open up more, we'll be able to have more of that, and we'll be able to network better locally, across the state, and across the different regions. Next slide, please. So, what are the benefits of being a member? So, the connections, we've talked about that. You're connected with a larger group of people, and when you're connected with a larger group of people, you have a larger network. Because I am connected with a larger group of people, when I need a resource, I know who to reach out to. If I'm looking for someone or something in the regional area, I'll reach out to someone in the regional community health worker group for KC. If I'm looking for something national, I'll reach out to Trevor Smith. She's our national ambassador for this region. I'll reach out to people for the state. If I'm looking for, I know all the people, because I'm on the state association, I know all the people who are leaders in the different regions in the state. I know who to reach out to in St. Louis. I know who to reach out to in the Ozarks. So I'll reach out to people. Except you are in the association, you're not going to know that. That's an advantage. You'll know the educational opportunities that are around. You'll be able to join in policy and advocacy. Why is that important? As community health workers, except we're out advocating for ourselves, nobody's going to push our agenda for us. All of us know in the room that the work that we do does not get direct reimbursement. You have to walk through a clinician for that work to get reimbursed. And the only way we can change that agenda is to get people in the forefront to push that policy and agenda. We don't want to have a repeat of what happened just before COVID, to get it, to just about get into where it gets mentioned, and someone who doesn't like us very much pulls it off of the agenda. So we want a lot of policy, public policy and agenda, and visibility. And the way to do it is come and get on all of the subcommittees that are available. We have various subcommittees. Become a member, sign up for one of the subcommittees. The policy and advocacy subcommittee is one. We are looking for members on every subcommittee. Next slide, please. Next. So, leadership, you can sign up. Once you're a member, you can then get on the ballot, be voted for into any of the powers. You can be recognized, you can get empowerment, and you can grow capacity in the communities where you work and empower them and show them that we can do this, we can change the status quo of our communities. Last slide, please. So how do you become a member? You go to the website, chwam.org/join us. The annual membership fee is $50. You can do it, you can sign up for an automatic renewal. You don't have to do that, but if you need to, if you want to, it will auto-renew. If you don't, you will get a reminder when it's time for you to renew. Any questions? None? Thank you.
Thank you, Florence. I hope everyone gets the opportunity to join the association. Our next session is going to be from the team of Kansas City Care Health Center to discuss eligibility challenges in opposition to Missouri Medicaid expansion efforts. Please welcome Juan Rivera, Anisha Barnes, and Sonia Fuller.
Hello, everyone. My name is Juan Rivera. I'm the manager of eligibility enrollment at Casey Care. So just kind of a little ground rules. We want this to be interactive, so we kind of have a shorter slide set. So if you have questions, please ask them, right? We've broken this down into kind of 3 sections. First, eligibility, so people kind of know who may qualify for this coverage. Second is all kind of the application issues that are facing the state of Missouri right now. It is not a smooth process. We want to talk about that because I don't think it's widely known kind of what's going on with those applications. So we're not really sure how to kind of talk to our consumers about that. So I want everyone to kind of get that information so you can take it back to people as you're talking through. And then finally, as we all know in a very public sphere, right, it has been playing out that they're kind of trying to undo some of this that's been done. So we're going to kind of talk through what is happening with that right now, kind of what's going on. So kind of a few additional things. We use consumers in insurance, so you're going to hear us using consumers a lot. It's the same as patient or client. I switch around sometimes because I used to be a case manager, so I apologize if I flip as we're kind of talking through these. And then additionally, we have a lot of acronyms in insurance. So we will try to catch each other. You might see one of us tap each other. If we start using acronyms because we use them so often, you'll see someone tap me, and so I remember to actually say what that means. So don't be thrown off if we do that to each other, okay? I'm going to let Anisha take it over for eligibility piece and kind of talk through what that looks like.
Next slide, please. So these are the eligibility requirements for AEG. Here I go using that acronym, Adult Expanded Group. So Missouri resident must reside within the state of Missouri, will need to be able to provide a mailing address to receive any communication from Mo Health Net offices. Next slide, please. And this is the income guideline, and off to your right, you can see the household size in the chart. So it's below 138% of the federal poverty level, which we call it FPL, another acronym. It is determined by tax filing household, consists of yourself, the spouse, and any dependents inside of that household as well. This is based on gross income prior to taxes. Next slide, please. You have to be between the ages of 19 and 64. Individuals under 19 may qualify for a children's health insurance program, which we also call that CHIP. Individuals over age 64 may qualify for another Mo Health Net program, which is called Age Blind and Disabled. Next slide, please. Okay. Here's one of the caveats to AEG, Medicaid expansion. Cannot receive supplemental income. Individuals who qualify for SSI are not eligible for expanded Medicaid coverage, but could obtain coverage through another Mo Health Net program, which is called the Age Blind and Disabled. Individuals with SSDI will be evaluated for eligibility within the expanded group while their ABD, Age Blind and Disabled, application is being processed. Next slide, please. And another caveat for AEG, individuals cannot be eligible for Medicare Part A and or B. However, they may be eligible for the Age Blind and Disabled Mo Health Net program. Next slide, please. Custodial parents with children. So custodial parents must apply for their children if they are not currently covered by Medicaid or other insurance coverage, like your private health coverage, if you will. Next slide, please. Okay, citizens or qualified immigrants must have a recognized immigration status. There may be a 5-year waiting period for individuals with a new immigration status, Refugees, asylees, and humanitarian immigrants may be eligible to obtain coverage despite the 5-year waiting period. And keep in mind that may underline that. Next slide, please. All right. So for the AEG, the acronym, sorry, the Adult Expanded Medicaid Group, so these are the individuals who may not be eligible for because there's other Mo Health Net programs out there that they may be eligible for. So they cannot be eligible for a Mo Health Net for families, Mo Health Net for pregnant women, Mo Health Net for age, blind, or disabled non-spin down, Mo Health Net coverage for former foster youth who have aged out of Missouri foster care up to the age of 26. Next slide, please. Okay, how to apply. So there are actually several ways in terms of applying for Mo Health Net benefits. You can always apply, and this is our best practice here at KC Care, via the web at mydssmo.gov. The reason why that is our best practice is because the processing time of the applications are actually like up to 119 days, I think, as of today's date. So this is the fastest method, but of course, if a consumer would like to still do a paper application, that's totally up to their discretion. Just go ahead and do a paper application if that's what they so desire. You can also apply by calling Family Support Division directly at 1-855-373-9994. Here's the caveat to this. So if that's more feasible for the consumer, most definitely initiate the phone call with the Family Support Division or provide the number. However, the wait time as of today's date is 3 to 4 hours. And that's if you get through. And you can also utilize an assister agency. So KC Care, we are a sister. I believe Samuel Rodgers is also a sister. If you go to either one of those websites that's listed on their screen, once you go to that website, you just literally put in that consumer zip code, and all of the assisters will come up, and that's who can assist. And all of the assisters are certified. So I know there's certified application counselor. So there's intense and in-depth training that goes into that, and we must pass all tests. And there's also what's called federal navigators, which is what myself and Sire we are. So there's a lot of training that we have to do to be able to do these applications. And if you can look it's on your right side, when you go to the website mydss.mo.gov to apply for health benefits, it will look like that screen there. And next slide. Okay, so I don't think we're going to play this video, correct? It's too long. It's too long. So I would encourage you to actually watch the video. We did leave slides here so you can have the resources, so you can have the link. It's about a 20-minute video, but it actually takes you step by step on how to apply for Mo Health Net benefits. And it'll also advise what a consumer may need, such as paycheck stub, verification of citizen status. So, yeah. Next slide, please. We don't want to play you. Okay, and here comes one.
So a few kind of lessons learned as we're talking through those last eligibility slides. There's a few things we've kind of learned along the way that could be very helpful, especially because you guys are working with people more hands-on. So first of all, you have to have a mailing address for your Medicaid application, right? Sounds like a simple requirement, but for a lot of our populations, that's not just like an easy, I always have a place to send mail where I can get it. Because what's going to go there is any request for additional documentation, if they can't verify something in their system, their card, once they're approved, like they're very important pieces that have to go to that address. So kind of be thinking through, if you have someone who really needs to apply for Medicaid, there are kind of things that might get in the way, and that address is a piece of those, right? There are many homeless community organizations that will allow people to mail, and that's a place to kind of start looking if you're having someone who's really struggling with finding an address. But I want to kind of throw that out there because that's a lessons we've learned along this process. We've had a few people whose application has fallen out because the address they gave us was not necessarily somewhere they could really receive mail, and we didn't prep them for what that could look like, what they might receive, what they would need to look at when it shows up in the mail. So just kind of a heads up about that. As well, Anisha did a bunch of digging and found a very, very good resource. The post office at Union Station, there we go. The post office at Union Station will actually allow someone to set up a P.O. box specifically for service needs. So like if they're doing a food stamps application, they're doing a Medicaid application, they have to go ahead of time, they will let them set it up. There's no fee associated with that. That is a huge thing that like no one knows about. Anisha did a bunch of digging for a consumer she was working at. We now have you all in a room. Use it if you need it, it exists, right? So there are those avenues out there. Just be prepped for your consumers may need to kind of know about that. Additionally, this program is meant to, oh, I see a hand.
That is correct. So if they have identification, a proof of ID, they would need to bring that. And also if they're currently employed, they would also need to bring a paycheck stub.
Good question. Oh, go for it.
In terms of our research, there was no age limitation or restrictions on there, so not that I'm aware of. Oh, so sorry.
We're going to repeat those questions and say those answers one more time.
Okay, so in terms of what I know, there's not an age restriction. So if someone is 17, they still should be able to utilize the post service that's located at Union Station. And what was the other question that I answered? What documents does one need? An ID, and if they're currently employed, a paycheck stub.
Very good questions. Thanks, guys. We're perfecting this as we go. It's been a long time since I've done one of these in person. So kind of the challenges we're looking at for applications right now, we're going to kind of walk through those. And I'm going to tell everyone, take a big sigh when we're done with this section, because it seems like a mountain. I promise it's not. We're all going to get there together. So the first thing, you will see a news story referenced here. There's a staffing crisis happening in the FSD office, Family Support Division. So they are really kind of going uphill right now. As of last week, luckily because we're navigators, one of us gets to sit on kind of the Medicaid meetings within the state of Missouri and kind of hear what's happening live at those meetings. As of last week, there were 100 people short in staffing. So that's a lot of pending applications we're sitting out there, like over 60,000, and we're down 100 people. So it's a lot that they're kind of struggling with right now. They're working to try to fill those positions, but even as they start to fill those positions, the additional piece that's kind of going there is there's training, right? It's not like somebody just drops in and they know how to determine eligibility for a Medicaid application and get that person approved. That person then is trained, they then do the application, and there's a period where they're having to be monitored by somebody. So they may process an application, it still has to be looked at again by a supervisor who then approves that application. All of this plays into these long timelines we're kind of looking at for processing applications. I feel like we should be honest with people about kind of where we're sitting now, and that's one of the things we're seeing. I like to be honest about it. It's also played out in the news. People are able to find this online if they wanted to. So we're talking about it, we're talking about it. Next slide, please. So there's currently some guidelines kind of already set up about how applications should be processed. We're not in line with those guidelines as of now, but I want to kind of talk through both on a state level, on a federal level, what we're looking at for timelines. So for the state policy on just a standard Medicaid application, it's 30 days is what they want to have from date of receipt to actual determination. For any ABD, age-blind disabled application, the timeline's longer because usually there's a medical piece. They have to determine that they're disabled. So for those applications, it's a 90-day timeline. So federal policy, because this is all kind of run through CMS, Centers for Medicaid and Medicare Services, their kind of guideline for what they want to see with these expansion applications is 45 days. So there's a little bit of a difference in that, right? The state has their own internal policy of 30. The federal government kind of says 45 is what we're looking at. However, currently we're looking at about 119 days. It's a long time, right? I actually, because we do so many applications at our agency, I'm tracking those kind of on a weekly basis. As of Saturday evening, when I did my last check of where we were at, they were processing 1216. So it's a very far back date we're looking at for them processing applications, and that kind of causes a little bit of hopelessness sometimes for our consumers who really need medical care and are sitting on this giant heap. But everyone's kind of in the same boat, and I think sometimes we just need to say that, right? It's not a perfect system. It is getting through. There are people that are watching it, and there are people that are kind of keeping track of those. And that's why you fall back on your assisters if you need your assisters, because we are monitoring those applications. We're trying to give them the best shot, so we're looking at them as they go through the system. Granted, it's a very long time delay. Go for it.
Has that been affecting like the back pay policies? Just I have some patients who it's been since October, but 3 months is
Yeah, so they should still be considering that application for the prior quarter coverage, that 3 months prior to. There are a few caveats with that kind of exist, right? They have to have identified that there's a medical bill within that 3-quarter period that they're looking to get covered. If they report no, because it asks for each quarter, like it asks for each month within there, if they say no to that, then it's not even going to be considered for coverage. They want to see that there's a need, and that is what identifies the need. But it should still backdate once it's approved, as long as there's no interruption in the application process, which is why I'm saying it is so important that people get their notices and follow up on those notices. Because if that gets dropped off and they start again, and where they can request that prior quarter coverage of 3 months, they've lost the initial point, right? That is now kind of lost in transit. So next slide, please. Okay, and then Anisha kind of referenced this. We're going to be honest about it. The phone wait times are intense. For consumers that are trying to figure out what's going on with their application, they're looking at a 3 to 4 hour wait. And that's like on a good day when they call in first thing in the morning. The system is also set up that if somebody doesn't get in queue, by the time that wait is supposed to kind of elapse, if they call later in the day and that is already 3 to 4 hours out and their close time is not going to happen by the time they would reach the top of the queue, they'll just get disconnected from the call. So the system's not built to help people currently kind of figure out what's going on with their application. FSD is aware of this. They are working on fixes as of now. But again, with how backlogged they are on applications, they're doing the best they can with the resources they have, and maybe we're just kind of stuck in this position now. So I'm going to give you a little tips and tricks of kind of things that we've seen that are working now, with the caveat that at any moment this could all change, because it seems to be that way with Medicaid expansion. So the online portal is one place that they're hoping to beef up in the future. Currently, the online portal does not give you any details. So if someone creates an online account to do an application, like Anisha was talking about at mydss.mo.gov, you could log back in there and you're supposed to be able to see what's going on with your application. Not a big detail, but like at least a little bit of what's happening. That has not been put in place as of yet. Now, if anyone logs in, it doesn't matter if they applied on December 17th, it would say pending on their application, which doesn't give you any kind of a heads up about where you're at in the process. They're hoping in the future to be able to drop the notices directly in there. So in the future, this could be very helpful, right? So if someone has changed their address, has not been able to get that address change done because there's a 3 to 4 hour wait on the phone line system, they have a place where they can kind of reference what might be happening with their application. We'll see kind of how that rolls out in the future, but it's a fix they're working on, and hopefully in the future that will be an option for consumers. Oh, go ahead. It's been kind of all over the place, I think, because of how much they're struggling to kind of keep on top of these applications. No, I mean, I've seen it where it's been like a few weeks, and then there's been times where I feel like it's been sitting there for much longer. Recently, that we have kind of a back access system as Tier 1 workers where we can kind of drop things into a portal that FSD can pull directly out of. And in those cases, it's supposed to move faster, right? Because I'm putting something in the system that they can pull directly out of rather than trying to filter through an email system, which is kind of how everything's worked with FSD in the past. You send it into an email, and that email is then checked by somebody and disseminated. But we're not seeing that that's moving very quickly. It's usually a few months back is what we're looking at as of now. So it's not a perfect system, but it exists, and we have a little bit of access to those kind of things, and we'll use whatever tools we have. So there's actually another place where it can be dropped into the system by the consumer. We're actually going to get there in 1 second. But no, it's a good question. Like you're intuitively thinking about where we're going next, and I like that. So there's a few soft launch changes that they've put out there but haven't informed the general public about. I have you in a room, I'm going to tell you about it so you can tell all of your consumers that it exists, because it has not been widely advertised that it exists, but it's there. So there's two tools. The first one's a report a change. The next one's a secure chat feature. So let's kind of look at what those are. Next slide, please. So on mydss.mo.gov, you'll see that little icon we talked about earlier, apply for services on the far left corner. 2 over from that, you can actually report a change. So that report a change feature is kind of a game changer. They don't have to have like an FSD worker on the phone. An individual can actually log into the system and drop that information directly into FSD's system. So they launched this, but then kind of quietly didn't really tell anyone it existed. And I don't think that they really have the manpower to kind of do that, to kind of get the word out there and to do a big media campaign. Well, we're here, I'm gonna tell you about it. I want you all to know kind of it exists. So the things that can be updated in there, household members, income if that's changed, asset limitations if those are changed, your address, changes in any expenses, any dependent care changes, child support expenses, and then there's a field called Other, which has been kind of a catch-all for any additional things. And then one thing I like to tell people is that Other field can be very helpful in catching an email address, because an email address is kind of where they're looking in the future for additional ways to reach people. So there's not a good way to put that in the actual change tool, but if somebody has an email address that is more consistent than their phone number, because we have consumers like that, tell them to drop it in there. Drop it in the Other field, it will get recognized and pulled and put into their profile as an alternate method to get a hold of. Next slide. The other one is the chat feature, same screen, mydss.mo.gov. At the bottom corner on the right, the MyDSS chat. So this is something that's kind of like brand new and just wasn't really communicated forward. It is kind of a place where someone could securely ask questions about their application. So as of 3 weeks ago when they presented this to a group I was in, they kind of talked about the time for that about 26 minutes for resolution, which is very different than sitting on call, or like sitting on hold for 3 to 4 hours, waiting for that to kind of get to somebody and then to talk about your concern and then to get it resolved. So it's kind of a robot feature at first. So somebody will ask a question, there is a robot that kind of queues them up, talks to them, tries to figure out what's going on, and then will move them forward to the next person. So again, as of now, this is a very good kind of way for someone to find out what's going on with their application, or if they're struggling with getting through the phone line and they want to talk to someone a little more immediately. If they're tech savvy and they can text, this isn't a method for them where they can kind of do all those things as well. The one caveat is the more widespread we get people aware of it, who knows if that'll slow down the processing times, right? Right now it's looking very good because I don't think a lot of people are aware of it. In the future, that could be a little bit different. But I want you all to at least know it's an avenue, right? Next slide. Okay. And then the next thing we're kind of coming across is the roll down application process, which in theory sounds very, very helpful. In reality, it has been another kind of barrier for some of our applications. So what they're doing with the roll down application process is everything goes into the same queue, right? You do that online application drops into the system, and it should be evaluated for any possible program they're eligible for. For most of those programs, they're known as MAGI programs. Modified Adjusted Gross Income, so they're based mostly on income eligibility. For those applications, they're kind of looked at for that income piece, and that's why they're all kind of going into one queue, because that's a majority of those applications. The people that get stuck in a never-ending loop are MHABD, which is our age, blind, and disabled applications. Those are not MAGI-based. However, because those individuals can't be easily pulled out, they're having to sit in queue for that 119 days to reach the top of the pile, only to be deemed ineligible for any MAGI level program, and then they have to move over to the MHABD side, the age-blind disabled side, for an additional 90-day determination period. So they're facing kind of even more of a mountain than our other ones. They're working to try to figure out how to fix this. They did figure out how to pull out individuals over age 65, right? So 65 and above, they don't even qualify for AEG. Age can be an easy way to say, get them out. Get them out of the MAGI system. They don't need to be determined for those programs. But for anyone receiving SSI, because they have to look at that application to figure that out, or anyone who's disabled under the age of 65, they're sitting in queue before they're kind of getting to the determination sector, which puts them at an additional disadvantage. So I like to kind of tell you that exists, it's out there, they're working on fixes, it's not fixed as of yet. We're kind of here now at the moment. Next slide. Okay. And then additionally, expansion has kind of changed a few things in the state of Missouri. I'm going to talk about two exact examples that we've come across recently. With any kind of a payer of last resort program, which many of our patient assistance programs and our FQHC kind of sliding fee scale sometimes are built into these programs where if there's a payer source in place, you're required to take that payer source, and then they only pick up if you don't have that payer source available, right? You've exhausted all of your options, expansion Medicaid being one of them, adult expansion group. So we have seen with Gilead, one of their Hep C medications, they're saying, no, you are eligible for expanded coverage. You will have to wait for that expanded coverage to come active before you can access the Hep C treatment. While in a financial world that makes sense, in a real life world when people are facing this long of a wait time for applications to get processed, as well as maybe missing a notice because you put in an application on December 16th, you're waiting for that application to get processed. We are now May. You may have forgotten to start looking, keep checking your mail, keep looking for that notice. You're then thrown out of queue and you're starting the process again. So we have people that are motivated for treatment and maybe don't have access as of now. It's not an ideal situation, but it is something to kind of be aware of. Not every PAP is following these same rules. For our hepatitis C, we actually have a team in our clinic that does that. They found another drug that they could use in lieu of that is understanding of the difficulties that Medicaid is facing in Missouri. But it is not across the board, and there are limitations now for some of our consumers waiting to kind of get access to some medications. Additionally, we've had a few discount programs that our consumers have used pretty regularly in the past. Some of those discount programs are now saying you are eligible for expansion coverage. You are not able to renew your application because you should be utilizing this. While in theory, that is great, in reality, we are now creating a barrier for people to access what they need. So FQHCs are a place to go, right? They're not every FQHC is in line with this. Some are still saying, come, we will do the slide, we will do the best we can with what we have until you kind of get access to that coverage. But just kind of a heads up. Ooh, yes.
Can you tell us what MAGI is again?
Yes, modified adjusted gross income. So it's the income determination wing for any program in Medicaid. Next slide. So again, with that prior quarter coverage, one of the issues we've seen is with long processing times, there are issues arise with that, right? So you have somebody who, especially during the pandemic, in October, November, December, were struggling with keeping employment, applied for coverage because they needed it for whatever medical procedures they were doing, whatever cost they kind of absorbed. And then they get a job somewhere in between then and now. They are then telling Medicaid about that change in income. Their applications then removed from the system without being considered for prior quarter coverage, for that time when they were waiting. So they're now saddled with all of these medical expenses. So there is another kind of issue that's kind of being thrown in the mix now that we're seeing. In these cases, Missouri Legal Aid is very aware of kind of all of the barriers that are going on with the Medicaid process. They may be your best advocacy tool. Lead someone to Missouri Legal Aid so they can advocate for that application to be really considered for those periods where they had bills that are kind of existing and sitting out there. But again, that's another thing that a consumer or a client would have to do in order to kind of be considered for that coverage. Because as of now, they're just kind of getting pulled out of the system. They're saying, we don't need to determine this, you're not income eligible, remove it, rather than thinking about all of that period of coverage. Next slide. And then with that, we're having kind of trust issues we're seeing with consumers. I know we started off very, very fruitful with a lot of people applying. Like we come out of the bat and we were having a hard time keeping up with how many people wanted to do applications when all this went live. They started processing October 1st of last year and we had people just flooding into our system. I feel like we're more chasing now, and I think that's because people are kind of sitting out there with no knowledge about what's happening with their application. So they don't believe that it's actually something they have access to. So there's one case that I'm aware of where an individual applied 9 separate times because they just couldn't figure out what was going on with their application. They just assumed that the application wasn't taking, which is a real concern when you just look in the system and it says pending over and over again, and it's been months with no notice from anyone at the Medicaid office about what's going on with your application. I've also heard from consumers directly that they just didn't feel like Medicaid was an option for them, right? And that don't believe that the new guidance we're kind of giving them about adult expansion group is real. You can get a coverage, like here are the qualifiers. We're still kind of getting that, and we're having people push back and say, I don't think so, because look, I'm still sitting here. And I'm like, I promise I can see your application. It's in there, I'm looking at it. We're just waiting. So I think it's kind of reinforcing that Medicaid is not for me thing we've heard in the past, or at least my team has heard in the past from consumers. And then additionally, we're kind of having requests to not have Medicaid because they don't feel like it's going to be helpful for them because they can't even get through the process of applying. So we've had a few consumers that have said, I don't want Medicaid, I want Marketplace. I want to be in a coverage source that I could have tomorrow, I don't want to wait, or I don't trust that I'm going to get it. Well, unfortunately, those systems work hand in hand. If you have one, you don't have the other. So it's not that easy. They are required to go to the expansion group. Marketplace doesn't really have a caveat to help them with premiums because expansion exists. They're supposed to work one or the other in tandem to kind of help each other. So we've had a lot of people that don't want the Medicaid coverage, and unfortunately I'm like, I promise it's good once we get you in it, we just got to get you through the process. Stick with me, let's talk about what it covers. So just kind of a heads up about what we're facing kind of with those as well, with consumer kind of faith in the program right now. Next slide. And then finally, kind of the big thing that's on the horizon that I want everyone to kind of be aware of. So some of you might have heard of the PHE, the Public Health Emergency Unwinding. That's a big thing that's kind of happening right now. Anyone who's familiar with the Marketplace, it's like a big message that's coming down from CMS. So during the health emergency, we've had a lot of grace with Medicaid. Medicaid has not required anyone to do an annual renewal. Normally, once a year, you get an annual renewal. They are verifying your income, your residency. Those pieces that make you eligible are still in place, and nothing's changed. Your household composition, all those things are kind of the same. That's been on hold. There have been no renewal notices since the public health emergency started. As well, individuals that might pop up and down on guidelines, like might be a little over income at one point, have been removed from coverage. They've just kept that coverage continuous throughout the whole time, because it was so uneven what was happening with our job markets, right? The public health emergency has been kind of a weird, wonky craziness, and they've been kind of adjusting and trying to keep for that. Is there a question? Okay. So with that kind of, it's coming to a close, or they're talking about the unwinding, which makes me think that it's coming. Current guideline for that is 7/15/22. That's when we're expecting the current state of emergency to expire. And with the unwinding materials that are coming down, I feel like we're headed towards the out of this. Well, when that kind of comes to fruition, we then have an onslaught of people who are going to have to do their annual renewals that have not done that process in 2 years, 2+ years. Or for our individuals that are AEG, Adult Expansion Group, they've never had to do this. If they weren't kiddos that had coverage and kind of had a knowledge of that process, they may never have had this coverage before, right? This group of adults who were covered was not a thing before that for Medicaid. So we're looking at kind of a group of people that may not know that this is coming, one. They may not have been able to update their address, their phone number, their email address with a 2, 3, 4 hour waiting time on the phone to be able to kind of update Medicaid that that's happening. And then if they get that notice and it is not returned, we're looking at them losing coverage, the cliff of kind of coverage, and then having to re-go through the process of 119 days. So it's kind of something I want everyone to be aware of. We are talking with every one of our Medicaid recipients. Anyone we talk to on the phone who gets to us somehow and has Medicaid coverage already in place, I'm like, have you told FSD about your address? Is it correct? Have you taken them? Do you have a new phone number? Is Medicaid aware? Has your email address changed? Is Medicaid aware? Because we want to set them up for the best likelihood that they will keep that coverage, because the converse of that is they lose coverage, they then have a gap where they may not be able to access all the things that they're currently on. while that application is back in process, which who knows what that timeline will look like if we dump a bunch of people out and they all start pushing their way back in. Oh, yes, go for it. No, it's right around the corner.
Quite a few. I'm a certified application counselor, and I have quite a few clients that have, qualified for the Medicaid expansion. So have you all created a flyer that we can share with individuals? I mean, I do follow-up letters, because of the long wait and the bottleneck in Medicaid. I know I have to do follow-up letters with my clients to let them know, hey, this is what's going on, and just give them a few examples and continue that communication with them. I would, with this coming up, this could be very overwhelming for, the family support division. It could be very overwhelming for them, the state. So is there something that we could send out to our clients to say, hey, this is about ready to happen. You need to make sure you've got everything up to date.
Yeah, CMS has an Unwinding toolkit, which has not only like social media posts, but kind of client-facing materials to kind of get them ready for this. So they do exist. It's through CMS. Okay. I'm hoping that everyone has access to these slides afterwards. There's built-in links at the end of this with all the resources. One of them is the PHE Unwind. So that is a good place to kind of start. We don't have any formal materials. We kind of lean on them for their materials since they already make them. I don't want to reinvent the wheel. But there are things that kind of exist to kind of get people ready. The toolkit is a very good place to start.
I know this has really helped my clients that I'm working with is just keeping connected with them and, doing follow-ups every so often. I'll do a follow-up with them to kind of let them know what's going on. Yeah. And I think that's the biggest thing that we can do is let people be aware this is what's happening. You're not lost. Your application's out there. Because I, too, have had people that thought, oh, they didn't get my application, and I had a client that had 5 applications out there. So.
Yeah. We're also looking at internally for our front desk staff because we have so many people filter through there. We're trying to make that little mydss.mo.gov change report thing like a scannable, I don't remember what those are called, the little scannable thing where it pulls up QR code, like a scannable QR code so that somebody could change their address right there. They see the flyer, they click on it, they change their address while they're waiting for their appointment because they're just sitting there anyways, kind of waiting for the doctor. So there are ways, we're trying to get creative, be creative too, but notify your consumers that it's coming. Next slide. Okay. So I know we're kind of running down on time. I like the questions, though. This is more important than the other stuff. I want you guys to get what you need for your consumers out of this. So let's talk about kind of what's happening in a public sphere with Medicaid and the state legislator. Next slide. So this all kind of started in a very public way, and this is all stuff you can find very easily by searching Medicaid expansion and the state of Missouri and kind of figuring out where we're at with things. So you can kind of see how this all rolled out at the very beginning. The voters said we want expansion Medicaid, and that process kind of started. The legislator kind of fought it right off the bat. They did not believe it was something that was needed for the state of Missouri. They thought the voters were misinformed, that they were led astray, and they kind of fought those pieces kind of going into place. I think that kind of set us, and this is my own personal opinion, I think this kind of set us up for where we are now, is that those conversations about needed infrastructure and how we were going to do this work weren't happening because there was even a question mark about whether expansion was going to be allowed to take place, if they were going to fund it. So I think a lot of this is kind of a never-ending cycle of we started in a bad place and we're trying to get out of it. So I think that's kind of where we started. Next slide, we're going to talk about where we're at now. So there's a current piece of legislation that is kind of making its way through that I want everyone to kind of be aware of, HJ 117, a ballot initiative. So there are some kind of already pieces that the legislator might be trying to alter within this and how we're kind of moving forward with this program. The first is they're trying to kind of take over some of that control of funding, appropriate some of those funds in the future if they need to. How they're phrasing this is that if the state is in a different place financially later and they feel that they need to use that money in a different way, they would like the opportunity to kind of take it off the table in the future. To say, we don't have the money for this, we're not going to allow expansion for this year, adults will not have coverage this year. And that could be a realistic possibility if they get this onto a thing and people vote, right? So just kind of a heads up, there is a kind of a financial piece that they're looking at, feasibility and wanting to kind of change the set nature of this, that this should be something that renews every year, but that this is something that they should look at financially every year. So just kind of a heads up. Next piece of that legislation, next slide. So the next piece that they're kind of looking at is they would like to initiate a work requirement for coverage. So you'd have to have some kind of a movement towards employment, education, community service in order to keep this. They're looking at 80 hours a month, about 20 hours a week, and you would have to kind of meet that requirement, satisfy that requirement to keep that. So not ideal, and we've kind of seen this play out in other states. As you'll see on the right side of your screen, Arkansas had this occur with their Medicaid expansion in 2018. And Harvard kind of did a study with what kind of happened afterwards. So Harvard looked at the group, about 18,000 people who were kicked out of coverage because they couldn't meet that requirement. They interviewed over the phone 2,706 of them and kind of talked about what that looked like post-Medicaid once they lost those benefits. In those scenarios, you found that about 50% of those individuals had problems with paying off medical debt. Not surprising, right? You don't have coverage, you still have medical concerns. We can't pretend that just because you've lost your coverage, your diabetic care or your heart disease care are things you don't need anymore. You still need those things, and then you kind of transition into a different facility where hopefully you can still meet them, but those facilities still have costs. And individuals were struggling with those costs once that coverage kind of left. Additionally, 56% delayed care because of the cost. Also not surprising that our consumers are kind of avoiding. I, as a medical case manager, when I used to be, I had this all the time. People were just like, I can't afford that. I have to feed my children. I have to be able to like pay for my expenses on my car to get to work. Like that wasn't their highest concern, and they were willing to skimp on their health care so the other pieces in their life worked. And then additionally, 64% delayed any kind of medications because of cost. So we've kind of seen this play out in a public sphere and kind of what it looks like, and those outcomes for health were not good when individuals were kind of faced with a choice, when they either had to choose their medical care or they had to choose every other day expenses. So in the Arkansas case, it's good to note that like it was overturned by a federal judge in 2019, but not before 18,000 people lost their coverage, right? And what does that do in a state where we're already having people that say, I don't want it because I don't trust it? If this is kind of a thing we're headed towards, it could then cause additional mistrust kind of with the program, or at least that's what we've seen and I think will happen in the future in our area. Next slide. Okay, so where that kind of sits right now is it's in Senate. It's been referred to the Government Accountability and Fiscal Oversight Committee, and they're hoping to maybe have it on a ballot for the voters in Missouri to kind of vote on late this year, August or November. So I want everyone to kind of be aware that that is coming, that this is something that you could see on the ballot. If you're a voter, please vote, right? This is important stuff, especially for the consumers that we serve every day in our communities. And I think that this narrative that we're hearing over and over again, that this is not something that needs to happen for Missouri is not true, right? I was actually talking at my table about this old colloquialism we've always had of like, pull yourself up by your bootstrings, right? Like, we don't need social services, pull yourself up by your bootstrings. Well, anyone who's worked in social services know that's like not a thing, right? You can't just say, I'm gonna lift myself out of poverty and be able to meet all my healthcare needs by just working harder. The system's not built fair. Always. People do not have the same opportunities. Even speaking to a Missouri group, we think about how different it is between cities on who has access, right? I can't pretend, being a Kansas City, Missouri resident, that I don't live in an ivory tower. We're a metropolitan area with a lot of services. You talk about outstate areas, right? You talk about those rural communities who can barely even keep their healthcare center open because Medicaid expansion has not existed in the past. It's a different ballgame for them. They don't have kind of all of these additional things to kind of fall back on. So it's important that we protect these services for our consumers so that they have the best advantage moving forward. Next slide. So I wanted to give a little, 1 minute. I took it right to the brink. I always take it right to the brink. Any additional questions that anyone has for us as a whole. And I have 2 federal navigators that are very, very, very good at the application piece. So if someone has one, let us know.
A quick comment, if I may. As you are assisting individuals with completing those enrollment forms for Medicaid, it is important to make sure that you check the box for the Extended Women's Health Services Program for any women 18 to 55 years of age. Although the wait time to get those processed is long, if you check that box from the get-go, it expedites them getting enrolled in those services if they're eligible, because that covers additional services that many women don't get covered through their regular Medicaid, and many, many people aren't aware of that one little box, and it gets missed. So just putting the plug in.
Thank you. Tips and tricks, everyone. Any additional questions?
Is there a way to modify the tools that are online for clients who have mixed status families that don't have a social security number, or they don't have a DCN number just yet? If we try calling, we can't because we need a DCN or a social. In most cases, most of the children are the only ones that have a social, so we cannot get through.
Yeah, that you're correct. It is a barrier to kind of doing that. The online change report tools is a good option for that because you can choose it for whoever the primary applicant is, and in that case, you could choose the kiddo, right? If the kiddo's the one that has the concern, I would put kiddo's name, kiddo's DCN, or kiddo's social security number so that you can get through that process. The same with the DSS chat feature. It should let you at least get through. What happens after that, I don't know. Any other questions?
2 things. Did you know that if you're on expanded Medicaid as an adult, that you have to sign up for something different if you're pregnant?
Yeah, there's pregnancy coverage, which is a required category. So yeah, they would move into that pregnancy coverage.
So a different application?
Not anymore. They're all kind of a singular application moving towards the same thing. That roll down process is supposed to assess them for any possible category across the board. So it shouldn't be, it's kind of the same application, but it is a long application for just reporting pregnancy.
And then what can we do to encourage our legislators to get this moving a little bit faster? Is there anything we can do to advocate?
Yeah, I mean, you can find all of your legislators online. Send emails. I'm never afraid to send an email. I'm never afraid to make a phone call. I want them to hear from me because if I'm going to vote and I'm going to be one of these people that's paying into the system, I'm going to have a voice. Whether you like it or not, I'm going to say what I'm going to say. If you choose to ignore it, that's one thing, but at least I tried.
Any other questions? Any questions from our virtual audience? Thank you so much.
Thank you so much for the time, guys. Sorry we took you right to the edge.
Thank you. That was very detailed, and I'm sure we all have lots to think about to process through all that information. We're actually moving into our lunch session now. So for folks who are virtual, we're just going to be playing some nice music for you all. And everyone else, feel free to move about and network. Lunch is available in the hallway. There is boxed lunches. There are vegetarian and gluten-free options, so if you need that, please use those. The next sessions will be breakout sessions starting right at 12 p.m. We will have breakout sessions in this room, in Truce Room, and in Brush Creek. So please reference your printed or digital agenda to decide which room you're going to go to. For our virtual audience, you'll be back here in this room with us for those presentations. Everyone will be back together in this room for our last session starting at 3 p.m. There will be a 15-minute break between each of the breakout sessions, so you can move between the rooms and network a little bit. So feel free to go grab your lunch, and we'll see everyone back in this room at 3 p.m. Welcome back, everyone. We are going to jump right in. So our first speaker of the afternoon is Justin Duncan, Chief Executive Officer of the Washington County Ambulance District. He has had a long career as an EMS and is passionate about mobile integrated health systems. This innovative approach helps patients manage their care and address health outside of hospitals. Welcome, Chief Duncan.
see if I can, oh, there, maybe, okay. I can't stand having a microphone, but they said I have to because there's folks that are going to be online. You can hit next slide, Ray. Thank you for the introduction. I serve as the CEO for Washington County Ambulance District, and I'm a career clinician first and consider myself a trader that I went and became the boss at some point back there. My greatest joy is still taking care of patients. It's the best job in the world. Don't get to do it very often anymore. I also wear a few other hats, and one is I serve as the state president for Missouri Emergency Medical Services Association, and we represent every level of pre-hospital healthcare provider across the spectrum, so we're inclusive of everybody. You can hit the next slide. So mobile integrated healthcare is something that likely you may have heard of. Most oftentimes it has been tested and experimented in the urban setting. There are systems in Minnesota that are very robust and have been around for a good while. And the high level is that mobile integrated healthcare from our standpoint is meant to be community specific and to address the individual needs of the communities. How many of you are community health workers? Okay. How many of you serve rural communities? Okay, cool, you're my people. So I come from a place that we have 760 something square miles, and we have more cedar trees than people. Our socioeconomics are very poor, and there was a group of us when this pandemic hit, and the title here is Navigating the New Normal. When the pandemic hit, we all sat in a room, and when I say we all, the ambulance service, public health, our clinics, our local doctors, our critical access hospital, and we just sat around and went, what are we going to do? We thought we were going to have this massive influx of critically ill patients. We thought the system was going to be stressed. We told people not to go to the hospital. We said, stay home. And then the patients never showed up. Or they did, but it was a little whiles down the road. And what we noticed is that we stopped seeing our chronically ill patients. And they didn't magically just get better, right? So we literally were sitting around the table and went, okay, you guys think about your frequent flyers. We'll think about our frequent flyers. You know they didn't just magically get better. Maybe we should go check on them. We were faced with laying people off. I didn't want to lay people off. My clinics didn't want to lay people off. They had a lot of people standing around doing a whole lot of nothing, and we put our heads together, and we went out with no money, and we started checking on folks. From that, MIH in Washington County was born. Early on in the pandemic, we learned that we had to band together, and especially when patients started getting sick and they started rolling in and they started overwhelming the system, we had those relationships built and solidified. And so early on, what stemmed from just kind of an idea, we recognized that there were people that likely would not have fared well, right? And they required a ER visit, admission to the hospital. And then there were patients that just ran out of their meds and they needed med refills, but they were terrified to go in because they had this laundry list of comorbids, and the media and we, as healthcare providers, said, don't go to the hospital, you're gonna get sick, you're gonna die. ERs need to be reserved for emergencies only, which I don't know how long many of you have worked in healthcare, but my organization is primary care to probably 70% of the patients I serve, and emergency departments across the country are primary care providers for a grand majority of their patients, right? Very little of what we do is emergency work. Next slide, please, Ray. So when we were sitting at the table, the healthcare piece is easy, but we accepted early on that we were going to treat the whole patient. And that's where you all come in. So I tell people that 2.5 years ago, what I knew about my FQHC is that they were the free clinic down the road, right? And now they're the greatest partners that I have. And I had no idea what a community health worker was. I now call our CHWs our gatekeepers, they're mission control, and they're the real bosses. They make everything happen in the background that we need them to make happen and that the physicians and the clinics need to make happen. So when we talk about good medical care, we also, things I don't think about in my profession, do they have access to food? Do they have access to electricity? Do they have running water? Do they have a functioning sewer system? If anybody thinks that people live in homes that don't have functioning sewer systems, I invite you to come and spend a day with me. we'll take a little drive and we'll see people that are living in places that they shouldn't be living in. And so whole patient is not just medical care. If you're not eating properly and don't have access to quality food and clean water, how on earth do I expect you to manage diabetes? I mean, that's just an absolute problem. So our goal was to identify and link, right? And it was built around telehealth. You can hit next slide, Ray. So the premise of our model is that a paramedic is designed historically as a physician extender. They are designed as a physician extender of an emergency room or an intensive care unit, depending on the setting that they work in. We run 911 calls, we take them to an emergency department, we coordinate care through the emergency department, we pick up a patient at a small hospital, take them to a big hospital, coordinate care through the ICUs at the tertiary care centers. So our model was, why don't we just tweak it based around primary care and needs of the individual patient. Next slide. And when we did these initial, I guess, test cases, we sat and went, who are your chronic utilizers? Who are your worst no-call, no-shows clinics, right? And who is failing the system? And then we identified our patients without a medical home. And we all know that there's lots of them, and we tried to find them a medical home. And all of this has evolved over the last couple of years with the high goals of making our patients better. Very, very, very simple concept. And for years and years and years, paramedics have been that weird glue that works with everybody. We work with the public health department, we work with hospitals, we work with clinics, we work with the primary care doctors. And especially in the rural worlds, you know, when I started learning what a CHW was, I went, well, we've been CHWs our entire careers, right? That's what we do. If you don't think that Miss Sally doesn't call down and go, can you go check on mom? I'm just worried about mom, and we, you know, she's just not acting right. We go check on mom, or we have our chronic diabetic patients that we go out and after they've taken maybe too much insulin or not eaten well, we cook them breakfast and we make sure someone's there to check on them. And Crystal's worked in my front office for 26 years, and she knows everybody. And they all call Crystal, and she figures out how to get things done. She's lost count over the years of how many people she's helped get on Medicaid and helped find specialty doctors. But we just didn't give them a title, right? Now we have a title that needs to be reimbursed. We'll go ahead and throw that out there into the mix. Next slide. So I'm at a CHW conference talking about paramedics, right? And we are talking about how those CHWs fit in. As I said before, I refer to them as mission control. So when our folks now go out, think telehealth on steroids, okay? First, for those of you who live in my rural world, how's your internet out in the sticks? Exactly. It doesn't exist, right? We're happy if we can get cell coverage. There's the bottom third of my county that still doesn't have access to 911. There are counties in Missouri and locations in Missouri where they don't even have access to 911, let alone internet. So when we said telehealth, right, we'll get mama on the iPad and we'll link them in with a physician. One, think about use of technology for the patient of, multiple comorbids, and then access to broadband. So the first thing that we bring is an SUV with a beefed up hotspot that has access to all kinds of cool stuff because, we need that from the emergency side of the house. And the second thing that we bring is a licensed clinician. Who knows and has heard of a community paramedic? Cool, awesome. So a community paramedic in the state of Missouri, it's an endorsement on our license to practice. And what it requires is that my business is built around emergent care and intensive care. And it takes them and it makes them half of a floor nurse. That's what I tell folks, right? It teaches the paramedics about wound care and navigation of resources and non-emergent cases. An example that I like to use is we access PIC lines and power ports all the time for the emergent setting. You know what we don't do? Disconnect them, because we take them to the hospital, right? And if they're sick enough that their port's being accessed or their PIC line's being accessed and we're giving medicines, they're going to the hospital. We don't disconnect them. And so those have been some of our lessons learned. So we bring a licensed clinician. We bring all kinds of cool toys. We have the ability to do labs, draw them and take them back to the health center, take them back to any location because we're officially subcontractors. We have the ability to do point of care testing. So we do A1C sticks in people's living rooms that result right then and there. We have iStats for other basic labs that we have the ability to do. We carry a full complement of life-saving equipment in the event that, well, one, the patient is a lot sicker than what we believed, or they are the closest resource to a true life-threatening emergency. They do multi-lead EKGs. So for any of our cardiac patients or our diabetic patients, we do that EKG to make sure that their heart is functioning appropriately. They do an in-home assessment. All of you know about your Prepare tool, right? But how honest are our patients all the times? Not, right? So what better than having eyes and ears in that person's home? And simple things like trip and fall hazards. Do we have handrails? Do we have functioning smoke detectors? Are they hoarders? Do we have unsafe living conditions? You can hit next slide. And probably the next one too, because I just kind of talked through these here. And we do the Prepare tool, and the CHWs coordinate that, but then we look at ways to identify and fill the gaps. So it's easy to identify problems. It's then better to address them and to close the gaps. You can hit the next slide for me. And one more. I'm weird not having control. So we took this in-home assessment here that is nationally recognized, and we adjusted it to meet gap closures and to trend the patient to see if we can get their living conditions better and what resources that we have addressed with them. So when we do our in-home assessment and we do the physical exam and we do our charting, because heaven forbid that all the charting software actually talk to each other. I've been in this business since I started as a volunteer when I was 16 years old. I've done nothing else, and our data at the level of the state still doesn't talk to each other from the emergency side from us and the hospital side, because that would just make way too much sense. So I can't get a heart attack data to talk and to do joint quality work, so we're a long ways away from the clinic side. And so the community paramedic does the charting, and it gets sent through. And I imagine that the community health worker pulls it down, if you will, from the cloud. So if they do a bedside echo, we do ultrasound for emergent patients. We can do echoes on a non-emergent standpoint. If they do an EKG, it all gets uploaded to the proverbial cloud, and the CHW then pulls it down into their charting software, make the notes, makes it visible, and then they get the provider on the line. The goal is to have the provider dedicated only as necessary. So just imagine if a paramedic brings in a critically ill heart attack to a hospital, they're giving a pass-off report to the physician. Well, now we're just doing it from a primary care standpoint. Hi, doc, we're here with Miss Sally. We're on our 90-day follow-up for her diabetes. Her A1C is this. Looks like we're trending in the right direction. EKG's normal, vitals are whatever. But hey, we noticed this wound that's new, that we asked the CHW to review the chart, and there's no notation. Do you want us to culture that wound? It looks not that great. Here, want to take a peek at it. Think we should loop in wound care, any add-on orders, and then those can be completed in the moment. Next slide. So the village, if you will, that it takes to make this happen is all at the core community health worker. So imagine if you didn't exist as CHWs, who would be the intermediary? Who's that middle person making sure everything's charted and documented and resources are navigated so that the paramedic has somebody to kind of almost do a hot wash in the moment on the patient before the provider ever gets on the line there. And we start all of that in the background and all that navigation process in the moment. One of our biggest barriers has been access to non-emergent transportation, so we have to rely on telehealth. We have patients that, and we can talk about some of our success stories that we have at the end, that we worked extremely hard to get them on Medicaid, to get them a primary care home. But then I have to get them 70 miles for a specialist appointment, and we have very limited non-emergency medical transportation. We have SMTS and OATS minimally, mostly for dialysis patients. And so we're trying to do things as much as we can from a telehealth standpoint, but there are just things that can't be done. So one of the greatest contracts I ever signed was with my FQHC. We have been partners through all of this, through thick and thin. In addition, we now operate, for the last 3 years actually, an EMS education program through our local community college. That started as EMT and paramedic. Everybody knows people don't want to get into healthcare right now. It's not exactly super fun. So we have gone with the model of building our own. Well, now we've built a community paramedic program, and starting, hopefully, pending state approval, in August, a CHW program as well, to educate folks in our community and show our model. So you have to have that, everybody coming to the table with the open mindset of what does our community need and how do we close those gaps. Next slide. Like I said, this all started with COVID. My plug here is, hey Justin, how much do you guys get paid for all this cool stuff? And the answer is, and I'm being recorded, so you can insert what's going on in my brain on your own, $0, right? We're grant funded, much like many of you CHWs are. So we have the grant dollars today, but my business is still referred to as an ancillary service. We are not considered providers in the eyes of CMS. We are transportation. I cannot bill for supplies. I could bill the patient directly, but what are you gonna get out of Medi patients or no insurance? Exactly. And so those reimbursements we're actually incentivized to take inappropriate patients to the hospital, because that's the only way that we get paid, irregardless of the services that we provide inside or outside of a pandemic. When COVID hit and got bad, my organization still to this day is the only one that's doing rapid swabbing 5 days a week in drive-through style. I'm still doing it to this day. We all know that COVID is not gone. This is likely our new normal, hence the cool title, right? We're just waiting for the next wave, and what's it gonna look like, and how bad's it gonna be? We started with swabbing of people in homes, right? We didn't want to bring those patients into a well area, so if we identified someone who was positive, it was easier for me to send folks out to their home. And one of my paramedics recently went, I'm used to sitting in the back of a 4x4 box with this patient with, where my knees are touching their legs. So going into their house is a lot safer for us. And I'd rather deal with them in their home versus in this really closed environment. Next slide, please. We started doing vaccination clinics. That's my garage. You will notice that you have a diverse group of human beings who came together. We put 18,000 shots in arms in the first year. I have a county of 26,000. I would love to tell you all of those 18,000 were folks from my county, but we have about a 35% vaccination rate to this day. We had people driving from all over. And we were doing 1,000 a day with all volunteers of different organizations coming together. And when I say different organizations, the county clerk closed her office to scribe for us. Public health closed their office to be the SMEs and the navigators. We brought in students, because I'm still a capitalist, right? I still run a business, and they're free labor. And any of you who are in healthcare during COVID, you'll want to know that there were waivers on clinical times. So a lot of clinicians that came out during COVID, paramedics and nurses, did not get ample or normal clinical time. They had more simulation time, but there is nothing like touching a human being, especially for these new kids that are coming out that have lived behind an iPhone or an iPad. I love to, and we're gonna use the word torture, but I love to torture them and just go, you have to touch your patient. You may not just sit there behind your laptop. You can touch them. You can say hello. You're not going to text them back and forth, right? You have to talk to them. It's okay. Next slide for me, Ray. If we remember the winter when the vaccine came out, it was absolutely beautiful and glorious, wasn't it? It was one of our snowiest and grossest winters on record, but we all came together for the common good. Now, I know that there's all kinds of articles out there about drive-through clinics and things, and people ask me, well, how was yours such a well-oiled machine? And I said, we've been doing drive-through vaccine clinics for years and years and years and years. It was just the flu. Or we were small. My public health department has 2 nurses, right? They can't put shots in every arm. We always took shots to people's homes because they didn't have ways out. And we knew from a proactive standpoint, we were better off to go get those high-risk people vaccinated for flu. Otherwise, we'll just take care of them later, so we might as well help them. And you got people sitting around, send them out to put shots in arms, right? Next slide. We, of course, brought in our nursing student friends as well. It's cheaper to pay for a student at a whopping $0 than overtime. Next slide. And they got a fantastic experience. What you see in the background here is our first SUV that we were able to get through a little bit of pilot money through the MPCA and Mo HealthNet through our FQHC. And what you see here is yours truly. So we're scraping the bottom of the barrel when I'm touching patients. That's what we tell people. And we're at a patient's home getting ready to do a monoclonal infusion. Interesting things. We stood up a monoclonal infusion outpatient clinic in about 48 hours. We saw this when Omicron hit. Our hospitals were overwhelmed. We were housing intubated patients in critical access hospitals across Missouri for days, and they were dying. So we were trying to keep folks out of the hospital, and that's exactly what we did. Next slide. You can hit the next one too. As you can see, this vehicle is fully equipped with emergency equipment, but it also has a refrigerator and beefed up hotspots so that we can charge our pumps, so that we can do monoclonal infusions in people's homes. Where do you bring someone who's COVID positive into a clinic setting without exposing a bunch of well people? Think about even hospital outpatient clinics. They exist. You have to march them right through the door. So I took it to them. I did very little of it. I hired very smart people that are much smarter than me, and I got out of their way. That's what I did. And who has infusion pumps that travel? I do. We hang infusions on patients every single day in the emergent setting. Now we're just doing it in a non-emergent setting. Next slide. Hit me one more, Ray. Our first funding, and we were so excited to get, I think it was $170,000 to at least pay for some staff, was on a diabetic project that was sponsored by the Missouri Primary Care Association through Mo HealthNet. And the project included the Great Minds Health Center, our FQHC. And we were literally sitting down with the pandemic. You know, like I said, people were sitting around and we were checking on folks. And the CNO said, in a very jokingly and sarcastic manner, could you help get my diabetic patients to show up to get their blood draws? And I went, no, but I could do it for you. And she laughed at me, and I think she thought I was joking. And I went, no, we have to deal with CLIA just like you have to deal with CLIA. Why don't we go to them? So we enrolled 21 patients in the pilot project, starting small, with a PRN person, one of my paramedics that just thought this was a good idea, and we were gonna put through some schooling. And we sent them out. The 21 patients came from the health center. I said, pick your worst. Who are your worst no-call, no-shows? Who had the worst A1Cs? And of course, it had to be straight Medicaid because of how the funding was, and we came up with 21 patients. Do you want to hit the next slide for me, please? We established our flows. We worked through the lessons learned of our telehealth equipment. We brought in this idea of whole patient. So I never dreamed that when I went to take care of a diabetic patient to draw labs and to do an A1C, that we would be coordinating dental. But one patient was quickly identified as having an abscessed tooth. And this is during a pandemic. And so we were able to get antibiotics called in. The paramedics were able to start an IV front load with broad spectrum antibiotics, which is what we do for septic patients, just a different key. And we arranged them for emergent dental. Oh, and now we're in the height of a pandemic, so we were able to swab them right then and there so that when they got into the dental suite, everybody was comfortable with taking care of this patient. Behavioral health. We are in the midst of an SUD-OUD behavioral health crisis in our country. Anybody who thinks otherwise is delusional. I speak to parents who want to have either their head in the cloud or head in the sand. And if you think that your fifth grader hasn't been exposed to, knows about, has friends that are dealing with drugs, again, you're just delusional, so we might as well accept it now and learn from it. I never thought that we would do telehealth from a behavioral health standpoint, right? The ones who say the magic words, who have a plan, we can take care of those. We can get them to a facility. Now placement's a whole nother issue, and we could spend all day talking about placement. But what are the ones that are, I just need to talk to somebody. I'm off my meds. I don't know that I'm on my right meds. Do they need necessarily in that moment an inpatient emergency room where they're gonna get thrown to the side and dealt with when we have time because they're busy? No. Why can't I telehealth with a LCSW or get them into clinic or arrange in the background all of these things? That's what community health workers do. Community health workers are not going to know about that patient or their needs unless there's a community paramedic sitting in their living room, whether it's for a diabetic problem or a high blood pressure problem. This is why we said we're treating whole patient right here. We identified some people in crisis and we were able to get them the help that they needed. That day, the help was they just needed to talk to somebody. They needed to get established with a clinic. They needed to get med refills. Next slide, please. So this is pretty darn cool. I was a biochem major. Back when I was going through school, I thought I wanted to be a doctor, and then I realized I came from poor people, and going to medical school isn't cheap. So I thought, I'll give this paramedic thing a try. And then I did some post-work in business management, and so I'm not the greatest statistician in the world. But 100% is pretty darn good. So when I say our initial 21 patients had a 100% success rate, I mean no ER visits for those patients, no admissions for those patients, every A1C improved, every core measure from a quality standpoint improved, and 100% positive patient experience. Every single patient is still compliant to this day. Now, did we follow the standard 90 days? No, these were high touch. We go out and we visit them on a recurrent basis. We didn't just go and draw their labs. There are patients, we now have a food box program in our community that was devised as a lessons learned out of this project. We had a patient who was only eating once a day and eating frozen meals from Walmart as a new diabetic, and everybody wondered why he had these peaks and valleys. Well, if you're a new diabetic and you're trying to learn a sliding scale, you gotta eat more than once a day. So the CHWs actually put their heads together and got food box deliveries to the clinic on a bi-weekly basis. And then the community paramedics, because they're in the home, get to provide referrals and then deliveries. In our system, any paramedic can provide a referral, any provider can provide a referral to the program, and without question. If we can tie it to a grant, great. If not, we address their needs, because it's the right thing to do. Next slide, please. I'm standing with a microphone in my hand on a HRSA-sponsored event, so I, of course, want to talk about our HRSA funding. So we took our initial results from our diabetic pilot project, and we used it to write a HRHI grant through HRSA, and it was through addressing heart disease patients. One good thing in my county is that we are extremely unhealthy. So when you're applying for grants and you're really bad and you have an idea to make it better, it looks really good on paper. So we got some money here, and HRSA helped us develop the community paramedic program through our community college. It was approved, and we are starting our third cohort in August. We have done a hybrid program to make it usable for folks across the state, and it's not just us. We're now touching about a 15-county region of folks that are attending education, and I went to a meeting yesterday in Lexington, Missouri, about folks that wanted to do a startup, and it was, we'd love to have your students, let's help you navigate through it or help you build. So we took our lessons learned from our diabetic patients and our diabetic study, and we simply applied it to our heart disease patients. Same concept, show up, assess, EKG, lab draws. We magically took the same assessment tools that they used in the clinic, and we're just doing it in the field. Next slide. Then came the CDC grant, and we were awarded $3 million through the CDC surrounding community health workers. And our push here, we're now a year and a half into the program when we wrote this opportunity, was COVID is bad in our community. We're doing swabbing, we're doing vaccines, we're doing monoclonals, we need more CHWs, and we got it. And from that, we're building our own CHW program. I have put a handful of paramedics through community health worker school, and every one of them came back to me and said, why didn't we do this? Like when we first got licensed, it would have been extremely helpful to learn how to navigate the system. And I said, to be fair, it didn't exist back then. So now we're gonna close those gaps. Our goal and our model is to do a license every community paramedic as a CHW, not necessarily to take the place of, but so they understand their line of thinking when they're in the field and make them more the team. Historically, our team was the paramedic and the doctor. Well, and not to take anything away from the physicians or the PAs or the NPs, but the paramedics and the community health workers, they gotta be on the same page or those resources are never gonna come back around to the patient. And so if we can give them the education, that's great. Public health. We historically would go give shots for public health. Well, public health folks, they like their mellow environment, right? So when we were in the height of contact tracing for folks, they were legitimately worried about people, right? And so if they were talking to folks and they were worried, we said, just refer them to the MIH program, call and give us a list, and if nothing else for peace of mind, we'll go lay eyes on them, we'll throw a pulse ox on their finger, and we did it. Our public health department throughout the pandemic has provided a referral to every COVID positive to our MIH program. Not all of them take advantage of it, but a lot of them did. Every COVID positive in our community was offered monoclonal infusions if they met criteria. My office and Great Minds office coordinated all of that, and when I say coordinated, I wanted signed orders from the physician when we started including these outsiders that we didn't work with all the time because they know their patients and we don't. So we were down to same day swab positive, shot in arm for monoclonal, which took a little bit of coordination to do. It either happened in someone's living room, as we see here, or my FQ had a dental trailer that they took on site to schools. Well, that dental trailer was not doing a lot during a global pandemic. So we parked it in a parking lot and we turned it into a clinic for monoclonal infusions. Completely separate, away from the clinic, not in a well area. And we're still rolling through our CDC grant today. We're trying to get shots in arms, and it's evolving. Next slide. This is kind of the sample of what our public health was putting out for folks. You can hit me with the next one, Ray. So we know we need to expand services, right? We need advocacy, we need more community health workers, but we also need them to be reimbursed. We need these services reimbursed. Grant money is great, but it runs out eventually, and these are extremely needed services to our communities. I can prove it in data from a clinical standpoint right now, and our next step and our future is proving it from a financial standpoint. Next slide. So before we go to these folks, I just want to preface with every person who we're mentioning in names has provided written consent. There's a patient here who we're going to talk about. Her name is, we refer to her as KF. Her only stipulation before she signed was, I get to wear my bandana, and the dog makes it in one picture. And we said, okay, whatever makes you happy. There we go. Next slide, Ray. So I'm going to talk to a story about Mr. Earl. Patient has multiple chronic conditions, limits his mobility with transportation, severe anxiety, hypertension, diabetes, all of that fun, cool stuff. You know, our normal patients, right? And so he canceled his clinic visit 10 times in 1 year. They were going to discharge him. We said, let's see if we can't give him a shot. We enrolled him in MIH, and he's now compliant. Next slide. Extremely poor from a socioeconomic standpoint. He credits them with literally saving his life and giving him the will to live. None of his conditions were managed, so you can imagine how he felt all the time. Next slide. Mr. J also has chronic conditions. His success is that he had received, or excuse me, his demise was he had not received any care since 2013 until he was enrolled in our program, and he was a cash pay. Between the community paramedics and the CHWs, he was enrolled in Medicaid. He now has a patient, or excuse me, he has a home, and he is compliant. The community paramedic literally had to sit with him and write out his application for him while the CHW was on the phone guiding them what to do. He would have been lost. Next story. KF is morbidly obese, underlying mental illness. She lives in the projects, no family, no transportation, no local support system. We're all nodding our heads. These are our normal patients, right? She had 61 ambulance transports and 61 ED visits in a 2-year period. That did not include the ambulance responses with no transport. That puts us into well over 150 visits in a 2-year spread. An average assumption is a 10% admission rate with her comorbidities. We enrolled her into MIH in 2021. And the first thing that we now do on every patient, thanks to this one, is a med rec. When your primary care provider is the emergency department, you get prescribed a lot of times multiple medications by the same provider. KF was on Haldol, which is a sedative, and she was prescribed it 5 times by 5 different people, and we wondered why she was altered. After a med rec and getting her a home, guess what? She's not altered anymore. Next slide. So we assumed a conservative cost of the system of $165,000, extremely conservative. These are based on Medicaid reimbursement assumptions only. It is likely a lot more than that when you look at her profile and getting head CTs every visit, lab work every visit, etc. Next slide. So KF is a person, Kendall Fox. You can kind of flip through these if you'd like, Ray, because we're going to show some pictures. This is a community paramedic in her home. Next slide. You can see why she can't get to a doctor on her own. Next slide. We're setting up a telehealth visit. Next slide. And that's Dr. Bass on the other end of the line. And as promised, her bandana and the puppy made the presentation. Next slide. So this is Kendall. She has, to date, in 22, 2 visits to the ER from well over 60 and no other ambulance responses with no transport. Conservative, based on those other assumptions, we're costing about $47,000 this year. Next slide. It comes out to 74% cost savings to the system. And I'm a capitalist, but think of the quality of life, core measures for a clinic for a no-call, no-show, and just think of her ability to function as a human being first. Next slide. Now, if you take that potential, we're into the billions. We all know that we see these patients every single day, and it just makes good sense. Next slide. We have to be sustainable, or this won't continue. I got my 5-minute warning back there, so I'm trying to speed up. Next slide. And this is how we started, a group standing around a table with just an idea of what are we going to do about our sick people who don't have access to care. One more. The point here is my business was asked during a global pandemic to not bring patients to the hospital. And as a collective whole, we rose to the challenge and we kept sick people at home. And I'm going to argue that I can prove we made them better and we built a system that is better. I'm not the first person to do MIH. It's being done across the country. Where we're unique is I'm the first MIH program in conjunction with an FQ, and our focus is on rural America. I'm happy to speak to any of you guys afterwards or answer any questions, and thank you for welcoming me to your world. Oh, okay, great.
Hey, can you hear me, Justin?
I can.
Perfect, awesome. I've gotten a lot of love for paramedics, EMT from the virtual audience, so thank you so much for your presentation and all the great work that paramedics do in their communities that they serve.
Sure.
A couple questions for you.
Okay.
How did the paramedic team partner with the CHWs to help the partnership for the community operate? Do the CHWs set up shop at the engine house?
So that's actually very interesting. The CHWs live at the clinic, which is a couple of miles away, and my folks, my community paramedics, wind up going there. So we've become more of an extension of the clinic, and you'll see that everything we've done is joint logoed. And my goal was that if we didn't have a shirt with a patch on it, you would never know who worked for who, and we integrated very well together. So actually, it's quite the opposite. The CHWs, while they come and hang out with us, their office remains at the clinic, and the paramedics round at the clinic, and that gets them comfortable with the providers, and the providers comfortable with them, and it builds those bonds and those relationships.
Thank you, Justin. Next question. Do you find it beneficial to connect with patients after an emergency event?
Absolutely. And so that, when I said every paramedic can provide a referral source, we have given them the opportunity that they can provide that referral from their cell phone by filling out a really simple form. And so connecting with them from the emergent visit, the goal is, okay, Mr. Smith had a complication from his cardiac cath, so we took him to the hospital. That could have been prevented. Let's get him signed up in the MIH program. And then there's some patients don't want it, right? But at least we extend that olive branch and we try to loop closure with them. And where EMS is, we're Switzerland, right? We work with everybody across the spectrum. And I don't care who their provider is, we'll go out and we'll do an assessment on them. The primary partner, of course, is our FQ.
Great, thank you, Justin. No more questions from our virtual audience.
Oh boy, okay.
So can you talk to us a little bit about how you all manage your schedule with all of the, I'm sure there's a lot of driving, and how you all
Yeah.
see the amount of patients you need per day? Like, what does your average kind of day look like?
So it is completely dependent on, well, first of all, this was a lessons learned. We tried to manage their schedule in-house and have the CHWs communicate with my office staff and scheduling, and that just turned into a nightmare. So we joke, the CHWs own the community paramedics, they manage their schedules, they build their schedules, and that has been some lessons learned. If you imagine a 760 square mile county, you can't have visit 1 up here and visit 2 down here. I mean, you can, but you're gonna get killed on your travel time. Average visits, very, very, very difficult to pinpoint, and a lot of it is an art, not a science. If I have a new diabetic being enrolled in the program, they're dedicated 2 hours. If it's a shot, they're dedicated 30 minutes so that we can monitor them post, unless there's a high risk that they need to be monitored longer. Our goal is, I like them to see 5 patients a day, but leaving room in their schedule so that they can do those last minute call-ins, right? So if they hear an emergency call go out that is paged as a very low priority, because we triage our calls and it's a known person in the system, they can add themselves to that assignment and potentially disregard the ambulance because it's not needed. But the CHWs own their schedule, and this was imperative because the CHWs also got the provider's schedule. Our goal is to keep the patient with their provider, right? They like that continuity. We also try to keep them with the same community paramedic. They like that continuity. So we gave their entire life to the health center for scheduling. Where are you from? I'm from St. Louis. Oh, you're not far from me. No, not far. I'm new into the CHW, but I've always been in this particular health center, and I have bills going on because I'm in the healthcare home department, which directly works with internal medicine. There you go. Trying to figure out how we can integrate this into that, so we can, because we have patients that are frequent flyers, as I like to call them. That's right. We call them frequent flyers. High utilizers is the socially accepted term, but I'll drop you my card before we leave and we can chat. We are having also an MIH summit that's going to be focused on rural in coordination with the Missouri Rural Healthcare Association on August the 9th. And we're going to try to have a panel of experts from across the spectrum. In my local network, I'm just one person. There's a lot of people a lot smarter than me. I just like to talk, so I get elected for this kind of stuff. But when I say we've gone out and talked with folks, I don't have a lot of experience in the big city, but I can get you in touch with people that do. And as the president of the Missouri EMS Association, we helped set up a program in Adair County recently. Like I said yesterday, I was in Lexington bringing together a CAW and a health center and EMS, And, while there's bumps in the roads and while people, we don't necessarily have to agree on everything, I bring it back to what are our mission, vision, values? We all have the same mission. We're all here to take care of sick people. We just come at it from a different angle. So if we can keep that in mind first and foremost, bring us back to the core being. We're here to take care of sick people. And it doesn't necessarily have to be how we took care of sick people 5 years ago. But happy to share and share best practices. Yes, ma'am. No. Much smaller. So there's about, I think, 6 or 7 of us that are up and running in Missouri. The grand majority are urban. St. Charles County has a large program. KCMO Fire. I'm meeting a lot of people tomorrow. I've never been to Kansas City, full disclosure. I've only just driven through on the way to Colorado. So I'm meeting with folks. CJC, Central Jackson County has an MIH program. Raytown has an MIH program. Cox Health is probably the only one because they have some urban and rural. So far, I'm the only FQ partnered program, but our missions align and we want everybody at the table and all inclusive. So those add-ons are trying to grow. We're trying to grow. That was our big push, and with opportunities that we're writing in, we brought in my neighbor because we're partners in care everywhere else at St. Francis County, we're looking to plant seeds. If we could get a seed from a real go-getter that it's trying to align really weird worlds, because I have a service area, and FQ has a service area, hospitals have service area, public health departments. So you're trying to marry all these worlds together and bring people to the table that arguably didn't sit at the table together. Breaking down silos. So I serve, yes, how's that? And with our changes in leadership at the department, we are very excited about the future, and someone who has come up through the ranks and who we went, hey, we know that person. Paula actually visited my county on one of her trips. I didn't get to meet her. I was out doing this. And the message has been put out there. And EMS, people forget about us. We are under DHSS. We are a neighbor to public health. I serve on committees under Steve Bolin and regulation and TCD, and we are breaking down silos. And this afternoon I have meetings with folks at the state as well. So it is absolutely taking off. Yes. Yes, ma'am. Okay. Uh-huh. Yep. That's right. Yep. Where are you at? Say that again. Oh. Okay. I'll give you my card, and you need the partner that goes out to the patient and that is a clinician and has a license, and together we make the team. So it sounds like your missing piece is my folks. Are you on the Kansas side or are you on the Missouri side? So KCMO has a huge program, and it's centered around high utilizers, and they have all kinds of partners, so I'll link you together. I'm actually going to sit with them tomorrow afternoon at Mark downtown. Anybody else wants to chat? I can hang out. I'm getting the look from the people telling me to be quiet. But I appreciate being invited to your world. I'm an outsider to your world, and but we're all here for the same mission. And I've learned so much from CHWs, and I hope that you were able to learn a little bit from me.
Thank you so much. That was amazing. I have so many questions, and I'm gonna keep thinking about it. So Other breakout sessions are coming back together, so there will be another one in this room starting at 1 o'clock. So, you look at your agendas and see where you next want to go.
Hello, everyone. Thank you for coming back again. We're going to start on our next breakout session. Community health workers have been found in a variety of settings, as we just heard, and that includes pharmacies. Dr. Bianca Daisy Bell is the Director of Clinical Pharmacy Services at CMO-RX. She will help us explore the relationship between CHWs and pharmacies and how CHWs can make an impact. Welcome, Dr. Daisy Bell.
Good afternoon, everyone. I am so excited to be here today to share our story about how community health workers started in our community pharmacy setting. My name is Dr. Bianca Daisy Bell, and I'm the Director of Clinical Pharmacy Services at CMO-RX. We have 3 pharmacies that we operate out of rural Southeast Missouri. Do we have any folks from Southeast Missouri here today? I'm sure they're here in our hearts and probably virtually. But rest assured, we are in Mississippi, New Madrid, and Scott counties. Our patient population has been described here quite frequently today, a very underserved population, and that really has a lot of care and high utilizers of the healthcare system. And so we'll explore this a little bit more today. And my role at the pharmacy is really to explore opportunities for reimbursable services, and a part of that is really leading the CHW mission at our pharmacy. I'm our CHW supervisor, and we have 6 employed CHWs certified on staff, with another 3 coming in this quarter. So we're very excited. Our technicians are very interested in the CHW model as well. Next slide, please. So my learning objectives for today, by the end of this discussion, you should be able to identify core responsibilities of pharmacy technicians and CHWs, discuss the similarities between technicians and CHW responsibilities, and identify expansion opportunities for community health workers in pharmacies. Next slide. So a little bit about CMO-RX pharmacies. We have over 45 years of experience taking care of our patients in the community, the boots on the ground. And we've really focused heavily on community. Care is local. The last breakout session I listened to really emphasized how, they're going into the communities and they're going to these settings. And really what I'm hearing today is that healthcare is local, and those local partnerships and relationships that you have with your patients. We have a very diverse pharmacy team. We incentivize our employees to partake in different experiences, such as motivational interviewing, technicians providing immunizations. We've had them go on the community health worker mission. We've also had them be a part of several grant opportunities that we'll talk about later today. And you'll see that this photo really culminates. We have technicians in this photo, we have pharmacists, we have the owner in this photo, we have residents in this photo, and they're not all showing the same certificate, because we continue to evolve based on the needs of our community. And so a couple of these certificates are mental health first aid. We've had our CHWs embark on that journey as well. There's also our community health workers that are currently on staff in these photos as well. Next slide, please. So when I was getting prepared for this discussion today, I really tried to take myself 35,000 feet back and think, what would my audience like to know about community pharmacy? And so I thought that maybe we could open the floor and we could just have a think tank session. What do you think of when you think of a community pharmacy? What comes to your mind? There are no bad answers. High volume, yes. What else? What do you think we do? Oh, deliver meds, okay, or other things. Love it. Anyone gonna say put pills in bottles? Because we actually still do that too. Talk to patients. And if you know your pharmacy from a long time ago, we used to compound and actually like make the drug. Some pharmacies still do that. Not as commonly as we used to, but there definitely are specialties where that happens. Next slide, please. So I love that. We're talking about increasing access. I just keep hearing delivery, talking to patients, counseling.
Bianca?
Yeah.
If you don't mind, just from the virtual audience, they had a couple thoughts that they wanted to share.
Please.
Someone mentioned where everyone knows your name. And then we had another participant share fill medicine and get advice about certain medicines.
Yeah, I love those, absolutely. And we definitely do those. And we're definitely high volume. And pharmacies do delivery. I put these on this slide to mention, we're still doing those things. We're still filling prescriptions. We're putting medicines in a bottle. Some people say we count by fives. We don't do that anymore. My machine does that for us, but yeah, we'll take that too. Yeah. Oh, wonderful. Yay, we have another CHW technician here today. This is very exciting. Yes. I am so excited. Wonderful. So we have some of our audience today who are embarking on this journey as well. And so that is phenomenal news. I'm glad that you're with us. Also, dispensing, flavored medications or compounding. As I said, we still do that from time to time. And then we certainly must not forget, considering our discussion today, our pharmacies are still providing vaccinations, probably more so than what we had in years prior, and that does not seem to be stopping anytime soon. Next slide, please. So there are several different roles at the community pharmacy. We typically, the roles on the screen are what you would see at a pharmacy. So we have the pharmacist in charge. That would be a pharmacist who oversees and manages the pharmacy in their day-to-day tasks. Then you could have a pharmacist. While pharmacies are operating, they do need to have a pharmacist on staff. They are the licensed healthcare professional that can provide education about medications, talk about drug-drug interactions, can look for additional opportunities to change their medications to help better utilize the medications that they're on. The pharmacies would not run if there were no pharmacy technicians. They really are the beat of the pharmacy. They really make sure that everything's taken care of. The technicians, they do it all. They do it all. From the minute that prescription comes into the pharmacy, gets filled, gives the medication to the patient in the delivery. Those pharmacy technicians, they are hard workers. And a pharmacy technician can be certified or non-certified by taking a test. They are licensed by the state, so you have a pharmacy technician license. And to receive or to become a pharmacy technician, you can either go to schooling. We've had several technicians who have done that. Or you can receive on-the-job training. So that's where we've really tried to embed the community health worker model. And then the second two examples, the biller or claim manager, that may be your pharmacist, it may be a technician, or it could be someone else, depending on your specialty. And then we have a human resource administrator, HR. This could be a role that's played by another person on this list as well. Next slide. So what does a pharmacy technician do? How can we define that? What are the roles and responsibilities? And I really tried to dig deep and find a definition that was supported by a pharmacy entity. And so we have American Society of Health Systems Pharmacy, and they say that pharmacy technicians prepare and distribute patient medications. Yes. They perform calculations. Absolutely. They collect patient information. They deal with insurance, which is a nightmare. If you've never done it, it's very challenging. Working with patients to get reconciliation. So like if a Patient gets discharged from the hospital. How do we address that? Using technology, we use a ton of technology in the pharmacy, whether it be counting medications or flavoring our medications now. There are wonderful technologies, or there's even systems that fill the prescription, the medicines in the bottle. So we do heavily rely on pharmacy technology to do our pharmacy workflow. And then, of course, ensure compliance with regulatory requirements. Pharmacy is a very highly regulated field, arguably probably one of the most regulated healthcare entities. There's lots of rules about the medications because a lot of them are high risk, and there's lots of monitoring that needs to go involved to make sure that patients are aware of the adverse effects and the whole system as an entity. Really, the pharmacy can be very, very highly regulated. So with that, the technicians also need to be aware of what the rules and regulations are from the state and federal level. Next slide, please. So when we embarked on this journey several years ago, it became very clear to us that maybe the roles and responsibilities of technicians isn't all our technicians do. So what do we do when a patient's discharged from the hospital and the technician goes to deliver that medication? And what we find out along our way is that there's leaves all over their steps that could cause a fall risk. And then when we get inside of the patient's house, we find out that they've been struggling with depression because COVID is real. And their son died because they didn't get vaccinated. And he spent months in the hospital, and she really hasn't been taking care of herself. And what is that technician going to do? That's when we started really thinking about, how about a CHW? Does our technician role and responsibility really identify what the work that our technicians are doing when they refer patients, when we know about the local nonprofits that help patients get the leaves off their steps? Or when they just provide a listening ear to that patient as they're struggling through their episode of sadness? Does that really define what I just said about all those things that they did? The lick, stick, and pour model of filling prescriptions? No. We do so much more than that. And so it became very apparent to us that we needed to redefine what we were, because if we're not doing what pharmacy technicians are doing, but what we're doing is great, we've got to figure out what's going to align with that. Next slide. So this is when we started our journey down the community health worker. As you know, community health workers are local professionals. They know about the local resources of their community. In the pharmacy, we know about the problems. We talk to the patients all the time. But the things that we didn't know were the solutions. And the community health worker course and curriculums and what they learn allows that linkage for that information to be shared so that we actually have solutions to the problems that were identified before. You'll see that, this definition talks about local care, trusted members in the community. Next slide, please. I'm not sure if any of you are familiar with the C3 project, but they went on a mission to task and try to identify roles and responsibilities of CHWs. And you'll see on the right-hand side, those roles and responsibilities were identified by a recent article published about what CHW technicians have been identified to do. And so what we're finding out is that pharmacy technicians in community pharmacy, where the care is local and we're going above and beyond, we're doing the work that the CHW core responsibilities are. Service coordination, getting patients where they need to go. We had a patient who really struggled getting access to transportation due to a weight capacity issue, so trying to find her specialized transportation to get her to the doctor's office. That was something one of our technicians did. She's a CHW. Initial counseling, setting them on their way, talking to them about their condition and what is high blood pressure and what does that mean for me. That goes along with health education. Advocating for your patient. If you know that your patient doesn't have a voice and that you need to help prop them up to get them what they need, and that's what they do. And care management, coming back full circle, taking care of the patients where they are in the community. Next slide. One thing that we always like to highlight about community health workers in this dual role technician position that we have is that they're social determinants of health experts. Why? Because the community health worker curriculum teaches them that. How do you identify those social needs? And having a resource binder to say, hey, if they have issues with food insecurity, these are your local services that you can find. And if I haven't said it enough yet, this is really all about local resources. What is in your community? And social determinants of health are conditions in which people are born, work, live, and age, which is what? Local. Next slide. So we've talked a little bit today about our reasoning for why we decided to go on the community health worker pipeline and why it was important to us, and how the community pharmacy could also benefit the CHW and the work that is going on. Studies have been shown that patients on average see pharmacies 35 times a year. We're very important in regards to being extenders of the healthcare team because the patients may only see their doctor 4 times a year. Well, what happens those 361 days? In between those appointments, who's checking in on the patient? Who's seeing what they may need? It's the pharmacy. They're getting their medications. They're getting refills. Those opportunities are appointments. Those are times in which a pharmacist, a CHW, could perform assessments, could provide education to the patient, could perform a screening. We have the people. They come to our pharmacy on average 35 times a year. And so utilizing that high touch point that we already have from the pharmacy perspective to really amplify the work that we're doing. Next slide. Pharmacy is a very interesting place in the healthcare team. We've seen a lot of changes in the last 10 years. What was once maybe considered high profit, you guys make a lot of money. You guys are with the pharmaceutical companies. You make millions and millions of dollars. Isn't true at all. Do you know of a pharmacy that's closed in your city or your town? Or maybe have you heard of a pharmacy that's sold out or changed names or sold to a mail order pharmacy? This is real. And it's really because the money that maybe was there at one point isn't. And so pharmacies are looking for ways to expand. And how can we showcase what we're doing? And if we're not just dispensing, how can we showcase ourselves to say, hey, we're doing more? CPESN is a network of pharmacies who have agreed to go above and beyond the traditional dispensing roles. And really, they want, we work to have services. And you'll see these services down here are ones that we've been a part of. Looking at patients' medication, seeing how we can save them money. We already heard about how medications are cost barrier. Well, is there an opportunity for a pharmacist to help them save money? The CPESN care model is really about screening. The most important thing we can do for our patients is to prevent them from getting to a place, right? Or to help keep their chronic conditions stable. But man, what a place the world would be if we could screen everyone, right? Because screenings can really help identify patients' needs before it gets too bad, before we have to talk about going to the emergency room. The patient is already coming to the pharmacy, so wouldn't that be a great place to screen? And then we send them to the doctor, assess, where the doctor can assess what they need. Maybe the patient doesn't need an office visit. Maybe they just need a listening ear. Isn't that a wonderful place for a CHW? And then the follow-up care. You go in and your doctor says what? You have hypertension, and you have to do what? You have to do something. Well, who's going to make sure that that something is controlled? How about if you can't get back to the doctor? Who's going to check in? Is this a place for pharmacy? So these are some areas that we've been involved with as a pharmacy, being extenders of the healthcare team. Next slide. I've talked a lot about local care today, but if I had to leave you with something today to really think about is, how is your care in your community local? Who are you working with that's local, that's taking care of the same patients? Because pharmacies, we're located in the middle of where people live, work, and age. Next slide. So I've talked to you about pharmacy technicians and what they do, and their role as being a dual role CHW technician. We've been a part of several grant opportunities this last year, and so I just wanted to take an opportunity to tell you what we've been seeing. We were a part of a 16-county vaccine COVID-19 hesitancy grant. And you're going to see that it was 6 months. But I think the important piece is looking at what months those were. Do you remember what life was like June 2021? Because I think that's an important piece to remember. Do you remember when you got your first vaccine? I got mine in January, February. So by the time that June 2021 came around, individuals who wanted the vaccine had already gotten it. But this grant was not for the people who wanted it to just go and get it. It was a vaccine hesitancy grant. And so we spent those 6 months. We had already gotten past the people who said yes. They said yes, they went and got their vaccines, and they're good to go. We spent our time on the patients who said, I don't know, not yet. Or are you serious? So this was a multi-county grant with multiple different entities. We worked with community health worker entities that were not pharmacy. We had them out educating the public. We had our internal team educating our patients, because we know that if patients are getting prescriptions filled on a regular basis, they have conditions. And what did we know about COVID? That patients who had chronic conditions were at an increased risk for serious effects from COVID. We had over 50 community health workers reaching out and providing education. And the goal of this grant was really to get where the patients were. And so here I was. It was July, hottest month of the year. And where am I? In the middle of a park, providing vaccine to patients. I'm at the beauty salon. I'm at the chili supper. I'm at the basketball game. We went where the people were. And at that point in COVID-19, that's what you had to do. Because the people who wanted the vaccine, they had already went out of their way to have gotten the vaccine. We did home visits. I can't tell you how many home visits I did. And I told you that we're in a very rural area, so we really went quite the distance. So we spent a lot of time going and vaccinating the community. But then we also spent time talking to our patients at the pharmacy where they were getting prescriptions filled anyways. We were going to call them about their medications. And so we added on, hey, have you gotten your COVID vaccine? They'd say, oh yeah, I already got that. Okay, cool, great, awesome. Have you gotten your COVID vaccine? I don't know if I'm gonna get that. Did you get it? And then the community health workers would answer, yes, I did get it. Okay. I can't tell you how many patients that just by having that person that they trust, that community health worker that they've been talking to for years and years, say, I got my vaccine, really push them to the side to protecting their health and getting vaccinated. As a result of our work, we had 46,000 vaccination screenings. So trying to make sure that our patients were taken care of. that wasn't really an angle that we had done before, is making sure everyone got vaccinated that needed to get vaccinated. We were preemptively screening to see if they needed the COVID-19 vaccine. And over 15,000 COVID vaccinations? That's awesome. I mean, we really did great work. Our community health workers just rocked this out of the ballpark. Once again, think about it. June 2021, and we got 15,000 people in a rural area where our vaccination rates aren't great either. And this is the work of the community health worker and the pharmacy team that was built to help support this grant. Next slide, please. Another grant that we've been involved with is with our public health departments. We've been a part of a grant called Empower, and it's a HRSA grant to help patients work on their blood pressure. And it's really a service where they coach the patient along, collect data, and watch their blood pressure throughout the coming weeks. A pharmacist is involved as well to provide clinical oversight to make sure that we're not missing any potential opportunities, or if the blood pressure is simply too high and they may need to do they may need to go to the doctor or ER. A part of this grant is really building the foundation of working with your public health sector. So we're embarking on learning about what the public health entities have to offer. So we've been learning about the programs that they already have at the local county health departments. And also encouraging the community health worker model. And so this grant reimbursed and covered the cost for the trainings for our technicians and for the pharmacies that were participating to receive CHW training. Next slide, please. We've published data. We're still currently in the grant, but our outcomes look great. We see here that this is a graph of our patients when they're paired up with the pharmacy for the self-measured blood pressure, that we see reductions in blood pressure. And clinically, this is great. A blood pressure of 152/89 is uncontrolled, not good. Increased blood pressure increases your risk for heart attack, stroke, and death, and we do not want those things. And so you can see here that we have statistically significant reductions in blood pressure from this program. Next slide. So something that we've learned along the way is that when you think about pharmacy, it's hard to differentiate. Not all pharmacies are the same, but how do you define that? How do you say that not all pharmacies are the same? You know, when I look at this beautiful garden, I don't know which one's performing better or which one's doing something different. It just looks like a garden, just like pharmacies. It's hard to differentiate. It's hard to know which one is going above and beyond and taking care of that patient when they get discharged from the hospital on a Sunday and no one's open. It's hard. It's hard to really define. Next slide. But you know what has helped us? Community health workers. It's really helped show the other individuals of the healthcare team, doctors, FQHCs, now the ambulance. It helps show how not all pharmacies are the same and how different pharmacies are different. It's really helped us identify what we're doing that makes us show that we're going above and beyond for our patients. We've seen the value of this course and why it's important for our team. I actually just got some testimonials from our CHWs. I was writing a blog post about, you know, if you were a technician and if you were on the fence, would you do the CHW course? Why or why not? And they all said yes. They all said yes. And they said, you know, it was what I was doing already, but it gave me extra tools in my tool belt. We knew the problems existed, but now with the CHW training, we actually have solutions to those problems and how I can do more for my patients. And so The technicians that have completed this course have really found benefit. And yes, they agree that a lot of this work I was doing already, but they also agree that the course really did help provide them with additional support that they needed in their role as a CHW. We've learned that there are grant opportunities to figure out how to be sustainable in the CHW market and how we can identify with other health entities. Next slide. One interesting area about community pharmacy that we haven't talked about today, and something that gets brought up a lot when we talk about community health workers, is the sustainability. I've worked hand in hand last summer with community health workers who, unfortunately, because grants have subsided, they no longer have a position. I'm proud to say that our technicians that are CHW dual trained, no one has lost their jobs. And I'm not saying that because they got CHW trained, but what I am saying is that pharmacy has been a sustainable place that allows us to explore grants, but also allow them to go back into workflow as the grants ebbs and flows, and we continue to figure out what our defined space is in the CHW and patient health. So what's on the horizon? I've talked to you about a couple of grants, and I've told you about the great work that our CHW technicians have done. We are, actually it's tonight, we're launching our first CHW course that specializes for pharmacy technicians. We're going to see continued growth in the number of CHWs in pharmacies. And we're planning on seeing increased utilization of CHWs in the pharmacy workspace. And if I haven't said it 18 times today, here's 18. Increase in local partnerships. Working with the public health department has been wonderful. It's been great learning about all the services that they have. And we've, identifying what resources you have in your community is only beneficial for the patient. There's great outcomes that can come of knowing what services that your community can provide, and the public health does a lot of great things. You'll see here that I have a picture of chicken or the egg, because I did not forget that today I'm talking to CHWs. And so you may be saying, well, if they were technicians first, can I be a technician? And we've had employees who have actually at the same time getting they were hired on as a technician and they were doing CHW simultaneously. We've seen different models. And I'd encourage you that if you're interested, if you think healthcare is fun, you like working in a team in a fast-paced environment, but while you can still continue to make good patient outcomes, I'd encourage you to look into being a pharmacy technician. If you're analytical, it would be a great position. And it gives me comfort knowing that pharmacy technicians, there's a place after, as we continue to explore those grant opportunities. Next slide. So now you say, okay, well, I think I'm gonna think about this pharmacy technician thing. You may be onto something. I encourage you to reach out to the Department of Health and Senior Services. We've been working with them closely on our community health worker course to help build a pioneer of community health workers that are inside of the pharmacies. And I know I had mentioned today CPESN, the Community Pharmacy Enhanced Service Network. As I said, they're a network of pharmacies that truly are dedicated to improve patient care, and they have specific requirements to be a part of the network that they do, where CHW and what they do closely align. So I'd encourage you to research both of those entities if working in a community pharmacy sounds interesting. Next slide. Why this all matters. Patients. That's why it matters. This is a note from one of our CHWs who went above and beyond in getting the patient what she needed, getting her a medical bed, spending hours on the phone with the doctor and the insurance, and making countless phone calls, getting her appointment set up. And it says, Michelle, thanks for going above and beyond to help me get my medicine. We do this for our patients. Next slide. I'd like to open up the floor to any questions that we have. Yes.
Just don't get that. Thank you. One-on-one with the pharmacist. As a matter of fact, I went in and got a prescription at my pharmacy just the other day, and I felt like I was just a number. You know, it was like, no, I was even looking at all the ladies in the back, and I thought, not one of them's even smiled. Not one of them has even said, hey, how you doing? So I feel like we need to get back to that, interacting with the community, because I felt like I would rather go to my doctor than to talk to the pharmacist at that point, because they don't know me. They didn't even want to know me, you know? And so I feel like that's a big issue that I feel like in the big chain pharmacies that I know they're worked to death. I know their hours are they don't have the help that they need. I get it. But it definitely is impacting the people who are on the other side going, hey, I'm here, you know, and that's where I'm just amazed at what you guys are doing. I think it's awesome.
I appreciate that comment because, you know, once again, it's like, how do you differentiate services that a pharmacy can provide? Especially when you hear about the things on the television, you know, there's things in the press about, you know, vaccines and all, you know, all the requirements that are coming through for the pharmacies. And, you know, it wasn't too long ago, they said that we were going to test and treat and shorthanded. Those things are definitely real. And so that's why I lead with not all pharmacies are the same. And finding the pharmacies that take care of your patients is now more important than ever. This is really that time when we're starting to say, you know, it's not just about the prescription number, it's really about the whole patient. It's really about taking care of your patients. But how can we do that in a way that's sustainable? Because if we close our doors, we fail everybody. And I can only think of the terror that could cause if we lost one of our pharmacies in our communities, because they remain a staple for those counties that we serve.
Hi, Bianca. I have a question from our virtual audience, and I apologize. That's really close to my face. Sorry about that. Tamara says, I work in a hospital. I think we should implement something like this here. How do I open up the line of communication? Should I go to the pharmacist first?
I think that's a great question. That definitely could be an area to start exploring. I would also ask who their CHW internal champion is, because, as I said, not all pharmacies are the same. Not all pharmacists are the same. And so this is a newer area of pharmacy, and it's really exciting. I'm very passionate. I think this is so cool that we're doing this, but there may be some pharmacists who may not be as aware or comfortable, but I bet that they'll know somebody who is in the CHW world or interested or listening, because that's definitely speaking volumes and trying to bring those two together. So I'd say definitely talk to the pharmacist. I mean, nothing can hurt from that, but also figure out who your internal champion is for community health workers.
So what role do the CHWs play when it comes to prescription access, especially for, like, I'm thinking of patient assistance programs or trying to find ways to fund and pay for prescriptions, because I know that's a huge barrier and access point that we see with our community health workers.
Yeah, they play a myriad of roles. Sometimes there's cost savings with manufacturer coupons. It's not unheard of that my CHW technician will go and search for a coupon for Atlantis, a very high expensive insulin medication. Or are there other grant opportunities that are in the area that can assist with the cost? Or typically we're not the ones to assist in filling out the applications. We like to refer. So that's the other thing, is that our CHWs are a great referral net because they do a lot of care coordination. So I'll have them work with other nonprofits that do help with the patient assistance program. Because before you send them to that program, you need to know, like, is that drug on there? You know, and being a technician, it's very helpful because you know what the drug is and you probably know what it's for. Also, looking at additional cost savings, you know, there's things that we can do in the pharmacy, you know, changing something from a 30-day supply to a 100-day supply. It can save patients a lot of money, a ton of cost savings. And then there comes a point where it's outside of a technician's scope, but maybe there's a different medication that's clinically efficacious. It works the same way, but having a pharmacist take a look at that and say, hey, you know what? Why don't we change the insulin to something that is covered, that's of equal efficacy? And so the technician is, you know, kind of that front line of trying to save the money. And if they kind of come up with empty hands, the pharmacist also can play a significant role because they're aware of the drugs, the classes, and what medications could be comparable. Those are kind of the areas that I've seen the technicians play in cost savings. And that's actually one of the big pieces that they do, is try to find cost savings, because if you can't afford your medication, you're not going to take it.
Do you guys participate in the 340B program?
Yes.
You do? Mm-hmm. Now, has it affected you by the new changes that they had with the income? Used to be the poverty level was not as high that you had to be able to participate in it, and they changed it. Mm-hmm. We've noticed that, you know, some people that's been on 340B for years, and then all of a sudden it's gone. Mm-hmm. And so I didn't know if you guys had another resource to people that don't have the 340B now.
Mm-hmm. Mm-hmm. So 340B is a very large topic that we could probably have a whole other seminar about. But essentially, it's a community benefit given by the government to help patients receive low-cost medications. But with that cost savings, there needs to be benefit to the community. And so different organizations do that in different ways. There's also different pharmacies that can participate. There's different regulations in regards to the pharmacies. So it's kind of a huge topic. But what I will say is that you know, pharmacies are still continuing to participate in 340B, and it does continue to change, as with many things that are coming down the pipeline. But we continue to still utilize that pipeline, but also looking at other resources as well, patient assistance programs, discounts. Sometimes I've even seen where their insurance, the prescription, you'll fill it at the pharmacy, and it's a $90 copay. And that looks great because it's covered by their insurance, but if you dig just a little bit deeper, the computer will say non-formulary. And so there's actually something else cheaper, but the patient doesn't know, because how is the patient supposed to know what's on their formulary? When they don't have internet access, they can't figure that out. So even just taking that extra step and looking to see, like, is this truly what you should be paying, is another absolute resource that a CHW technician could play.
All right, Bianca, I have another question from our virtual audience. What are the strategies you all are using to engage with patients when they come to your pharmacy? Do you target specific patients? Are you the CHW/techs going out into the community?
I'm going to answer this in 60 seconds or less. So we do both. As you all know from being CHWs, a lot of the work that we do is grant funded. So if there's a grant that supports us in going out in the community, we we have them do that. But we are also community members, and we're also helping. I can't tell you how many times I volunteered at the hospital to load up vaccine for the hospital. We deployed our own technicians to go and swab for COVID testing for the hospital. So we definitely give service. We help with grant opportunities, how we identify our patients, usually by their medications. If they're getting something filled, does a grant opportunity cover for that medication? Are they on a blood pressure medication? Could they benefit from the blood pressure program? Have that conversation. We do utilize a medication sync program where we call them on a weekly to monthly basis, check in on their medications. So we've utilized that before. So we do it all. And not one way is going to work better for a pharmacy versus another. Well, I thank you all for your time. This has really been great.
Thank you, Dr. Daisy Bell. So we will start on our next session in about 15 minutes. So have a break, and we'll be back here for the last breakout session. Thanks, everybody. All right, thank you, everyone. We are now into our last breakout session. And this session is going to be led by Dr. Manuel Solano, who's the Director of Behavioral Health at Samuel U. Rodgers Health Center on mindfulness. He's going to lead us through this session, tell us what it is and how to use it. Thanks, Dr. Solano.
Thank you. Can I use this microphone? This on? What about now? Okay, perfect. Thank you for having me. I appreciate the time and the opportunity. Next, please. I have a quick disclosure. I work with Samuel Rodgers, who is one of the sponsors. I don't think that is giving me a bias. This is a generic subject, so not a big deal, but I have to say that. And next one, please. So today we are here to talk about mindfulness. We hear about mindfulness, and everybody has this word here and there all the time, but what is really mindfulness? And there are many, many, many definitions. The ones that I go for is focus in here and now. So the formal definitions is the awareness that arises to paying attention on purpose in the present and not being judgmental. Okay, so just focus in the present. We spent a lot of time in the past, and we spent a lot of time thinking about the future. So all the slides are back there. There are copies, so feel free to grab copies. That way you don't have to take notes or pictures, but back there on that table you can find copies of this. So this is really hard because all our lives we have been trained to make judgments. It's a survival skill. Without being judgmental, we cannot survive. Every single minute we are making judgments about our work, our life, how to respond to a specific stimulus, what to do. So our brain has been connected and has been creating connections depending on our own history. Thanks God, now we know that something called brain plasticity allowed us to rebrain and reconnect and create new connections. So if you are familiar with some techniques, EMDR, everybody knows what EMDR is? Just in case, it's that technique that now in behavioral health we use to repurpose, refocus, rewire
the brain, especially with PTSD. So using eye movements and asking the person to focus on something different, their behavior changes. So we know that we can do that. We can do that through music. We can do that through meditation. We can do that through exercise. There are many things that rewire our brain. And that is what this training and mindfulness is, rewiring your brain. Because it is already set in a particular way that deviate and create a bias for you, and is the lens that you use to see your life every single day. And is not always the best. Next, please. So, just if I give you, any of you, can you catch this? Okay, what do you have in your hands? Rubik's Cube. Okay, can you solve it in the next 30 seconds? No? Okay. Who can do it? Okay, you already make a judgment, you see? Mindfulness is not making a judgment. It's, okay, what happens if I just observe this? If I learn to observe. And there is something that sometimes we do not observe, and it's our own life. We are so busy doing, we are so busy reacting to everything that we do not spend the time focusing in our own life. When was the last time that you seriously reflect about your life? About you today, your now? Most of the time, we focus on what happens yesterday and what is going to happen tomorrow. We never have time for today. We never have time for now. And I'm going to use a couple of experiences. You know, your words create your reality. We know that in the brain, whatever you think, whatever you tell somebody, if you start talking about playing basketball, your brain in a PET scan illuminates the same parts that as if you were playing basketball. So this is science. I don't like anything that is not based in science. So I am going to use examples. Everything, the examples that I'm going to use are based in science. So I'm going to use big words, neurotransmitters, hormones, things like that for a little bit. So please bear with me. And it's not by accident that I focus on this. My training, my background is an MD, and when I was starting my first residency in internal medicine, I was working in the emergency room. And I was working in an emergency room in South America, Colombia, during the Pablo Escobar era. If you know anything about the cartels in Colombia, the war that we had there, the bombs, just imagine what it was working in the emergency room and being a resident. Here in America, we have laws that protects the residents, limit the time. There, it is as needed. So at that particular moment of my life, this was as I mentioned, my first residency, I was at the hospital after I found out a week without going to my house, without doing anything but staying in the hospital. Of course, I was exhausted. And all of a sudden, I had nothing to do but find a place to sit down, and I fall asleep. Fall asleep in the emergency room, and then, of course, something happened. A bomb explodes someplace in the city, in Bogota City, and injured people came, right? But at the time, you can see body parts because it's grows, but if there's an explosion, everybody brings whatever they find. And I saw that, and when I finished my shift, what I did is I was driving a bike at the time, okay? My sports were skydiving, scuba diving, and I'm going to say again, and I have a bike. Going out of the hospital that day, all of a sudden I think, what am I going with them? Where am I going with this? What am I doing with my life? And I start reflecting, and I found out that, gosh, I'm trying to end my life. I don't have a life. I do not have. I was as a resident. All my time was in the hospital. My sports were, life-threatening. I'm sorry. And I was driving not a regular bike, a motorcycle in Bogota City. With the traffic, if you have been in any place, Lima, in maybe in Africa, any place you will see, Mexico City, the traffic is crazy. So if you are driving a motorcycle, you're playing with your life. That stop, that was a really hard to stop in my life. And I have to start thinking, what am I doing? That was the start of my journey through mindfulness. Now, after 30 years of that, 4 years of psychoanalysis, a residency in psychiatrist, I find out that the only thing that I was missing was to think about my present. Of course, at the time, we didn't have the new diagnosis that we have now. You know that ICD, the International Classification of Diseases, the 11th version has the burnout for us as professionals, any of us. But when we do not find out that we are burnout, when we do not stop and think, we are getting close to a mental health problem, whatever it is. In my case, I was looking for escape. But some people do something different. What is one of the most frequent? Alcohol, drugs. And you know something that the chronic stress does, and I'm going to explain that in a second? Increased pain, inflammation. There's a substance called cortisol that at the beginning, controls and manages inflammation. But if we produce that in excess, inflammation increases. So everything hurts. And what is one of the first signs of stress? Your neck hurts, your head hurts, something hurts, whatever it is. So what do? You start taking pain medicine, you start looking for alternatives. And we forgot, and we forget that there are many things in the daily life that may help us to focus in just the present. And that's something that is hard to do. Because, if you ask, what are you thinking right now? What are you thinking right now? But if I ask you about, were you concerned about something yesterday, something that happened at work? You probably will, I won't ask, I don't want to know. But chances are that if I ask you, what were you concerned about, you will remember right away. And if I ask you, what is something that you want to do? Again, the past or the future, but not the present. It's hard to be focused in the present. So we have to learn to do that. That's the challenge. How do we do that? Next, please. So this is a couple of the hormones that I mentioned, but I'm going to talk about toxicity. I talk about inflammation, I talk about toxicity. People, things by itself are not toxic. They do not damage us unless we allow those things or people to damage us. So the problem is not what happens. The problem is what do we do with the things that happen? And the challenge is we do not take the time. We react. Just what I did with the Rubik Cube. I ask you a question, we react instead of observe. Mindfulness teaches us, hey, just feel the moment. Don't judge. Just, if it is a complex problem, don't judge. Don't think if you're going to solve it or not. Just look at it. Maybe analyze it later, but first, soak yourself in whatever it is. An example is, okay, we are talking, and to somebody, one of our friends. We are thinking about, oops, my phone is ringing. We talk to the kids, and we have the phone right here, right? We are thinking about the emails. We are thinking about a lot of things. It's really hard to focus in the moment. Something that we call our culture, or civilization, or whatever it is driving us to focus on anything but us. We can focus on our kids because we need to be productive. But at the end of the day, many authors, when they are writing books, there's an Australian author that wrote a book, this is a doctor, and she mentioned what are the 10 things that most dying people talk about. Okay? And the first is what they didn't do. Okay? Why I didn't do this. And out of the 10, what is interesting is that out of the, in the first 10 reasons that they regret, there is nothing related with something that I did. Number 11 is, oh, I did this wrong. But the first 10 is why I didn't do this. And the first one is why I didn't have more time for me, for my family, for my kids. And we are always postponing. So our situation, our life, that thing that we call civilization is always moving us to postpone our needs because somebody needs us. And community health workers are trained to postpone all the needs. If somebody, physicians, anybody who works in healthcare is trained to postpone the needs and put the patient's needs, the client's needs. So this is a call to please pay attention to yourself. If not, you're going to burn out and you're going to pay a high price. Chronic diseases, research shows that diabetes, high blood pressure, high cholesterol are triggered by stress. And stress is triggered by cortisol. So toxic people do not exist. We made them toxic. What if, instead of thinking about toxic people, you think about vitamin people? This Dr. Marianne Rojas, she's a Spaniard psychiatrist. She's really, really good. If you want to check her and her videos and TED Talks, she's really good. And this is from her. What if instead of thinking about toxic people, we focus on vitamin people? Who is that person who gives you the energy? It doesn't have to be the significant other. There are people who may calm you. For me, my grandson, for example, playing with him, spending time with him, calms me. He energizes me. So think, I'm going to give you 10 seconds to think, what is that person that is a vitamin person for you? 10 seconds. Who wants to share? Go ahead. Granddaughter. Great. Somebody else. Granddaughters again. Okay. Great. We have to find that. So we have to exercise. And without doing anything, just by playing with vitamin people, we feel better. Why? Because we focus on them. We are there. When you're playing with the 9 years old, you're there. You're not paying attention to your phone, to your calls. Same thing with your grandson, granddaughter, significant other. And the other thing the other lie is that our kids or our significant others do not perceive when they do not have 100% of our attention. Yes, they do. We invented something crazy, and a word that is called multitasking. Multitask doesn't exist. You jump from one place to another, and that's what your brain chose. But you cannot multitask. And especially males, we are really bad at that. Females have a different hormones and alert system that allows them to pay attention and jump from one task to another. But males, we are not wired in that way. So that is something that doesn't happen. Okay. So please, if you have nothing and you do not have another takeout from this session, think who is your vitamin person and enjoy that. Because the other thing is, moments do not last forever. It's a moment. For some people, life is a moment. But what is your moment? Do you want to let that go? It doesn't come back. Once your grandkids grow up, they do not go back. Once your kids grow up, once you grow up, opportunities do not repeat themselves. Next, please. So, what we have now is we're measured by standards of perception. What does it mean? Your boss maybe asks you, this is the perfect standard. Everybody expects something from you. So, but maybe, if you're perfectly calm when somebody just crosses you on the streets, or when somebody jumps in front of you after 2 hours in a line, or if you do not feel envy when one of your coworkers go to a conference and you cannot, especially if it is out of town and your boss is paying for everything. But if you love everybody all the time, even when they are, all your clients and patients, even though when they are very rude, so probably you are like my dog. You have to be a dog if you have no feelings. Because we have to react. The only animal that I know so far that doesn't care and is always happy with me is my dog. Because he doesn't care. He's always happy, even if I leave for 5 minutes, when I come back, he's happy that I'm back. He never asks me, hey, are you mad at me? He's always happy. Why? Because he leaves the moment. And if we can leave the moment, we have no grudges. And we do not anticipate the future. But it's hard to do that. Because the whole life we have been trained to do the opposite. So, next please. And this is not mine. I'm not that bright. It's from Dr. Shauna Shapiro. You can follow her too. TED Talks, In there you can check her videos too. And there are small tips. So it's a mix. This is not new knowledge. I just took and still here and there from a lot of people and put this together. So what your brain does with all this information is manage all this uncertainty. But what is going to happen tomorrow? One of the problems that we have right now is that we cannot predict what is going to happen in the next 10 minutes. I have to turn off my phone in order to be able to talk and present this lecture to you, because, or lecture or conference, or why? Because somebody may call me. We have that addiction to notifications. Okay? How many notifications do you have in your phone? How many apps? Guess.
Apps, I mean, 30 maybe.
Oh, you're...
I've got 4 right now.
Okay, very conservative. How many notifications do you have, or how many apps?
I think I have like 30 or 40 as well.
Okay. Then if you are really serious, you easily have 100. Because you add and you add and you don't know. Just check the unused messages, unused apps, and you will see that you have a lot. Because you add and you don't know what you are adding. But those notifications are disturbing your here and now. You cannot focus in your here and now because you're always thinking about, oops, who's calling me? Let's see, what if? And this is worst if your brain is in development. For example, for teenagers, if you ask them, did you sleep well? Can you sleep? They will tell you, yes, we can. And then if you ask more questions, you find out that they check their phone 3-4 times at night at any time. So what sleep quality can you have if you are doing that? So we depend a lot on our phones. We're always plugged into what may happen. What if I missed a notification? What if? And everybody knows and that screens and games and everything are designed to capture your attention. It's by design, it's not by accident. Mindfulness is the opposite. Let it go. Relax. Don't think. Focus in the present. Focus on you. And that's really hard. Because, again, if you're a mom, but your focus is on something else. Your boss is asking you to focus on something else. Everybody's asking something from you. So if the brain managed this in a specific piece called the hypothalamus, where you have the amygdala, which is the part of the brain that deals with fear. And because, okay, what happens with these notifications? So what do? You start anticipating that and checking your phone. So it becomes overactive. You start releasing cortisol, inflammation. We have more cases now of arthritis, chronic diseases, high blood pressure. Cortisol is generating a lot of problems right now because of the inflammation. We're talking about diets to compensate for inflammation. We are talking about beverages that are generating inflammation. There is a specific connection between your brain and your guts. For me, it's kind of my second brain. If my guts start making noises and like colitis, all kind of problems that you manage in your intestines are related with cortisol, fear, overreaction. Your brain is generating that. Next, please. So that is the evidence. And what do we know? And how do we know that mindfulness is effective? Just last week, in 1 week, what I checked, they were submitted to a particular magazine, 32 articles in mindfulness. Next, please. So the evidence today shows that mindfulness, and that means focusing in the now, not in the past and the future, really works. And really works for specific conditions like depression, stress, and anxiety. If you push your cortisol too high, you release more hormones. So what happens with that is the level becomes lower and lower and lower. One of those is dopamine. So you're spending a lot of that hormone, and your mood decreases. So your chances of depression are higher and higher. That's why we are in a bad mood when we are tired. When we eat some things that generate inflammation, we may have some reactions that we do not expect. That's why we talk about the Mediterranean diet, with many diets. But the beauty of mindfulness is that it works in a different way for each person, but there are some generic steps that I'm going to mention in the next 15 minutes. The other area, is chronic pain. I mentioned that cortisol increases inflammation, increases pain. We are becoming really sensitive to pain. We are training our kids to be really sensitive to pain. For the epidemic of the opioids epidemic is a reaction to our fear to pain. Because we are so afraid of pain that I think Motrin in your babies, if you have kids, small kids below 10 years old, find out and think about yourselves if you took that amount of Motrin when compared with your kids. If something happened to them, Motrin. And we start medicating and creating the environment to have problems with pain. We do not tolerate pain, as we do not tolerate frustration. Depends on the generation. So we are complaining about an opioid epidemic. Yes, that's true. But is the environment generating that? Is the environment helping in this process? So what are we doing about that? We know that, of course, it affects performance. If cortisol is up, so you're jumping from here to there, how many days in a week you find out that you were really busy the whole day, but if you try to find out what did you do, really accomplish, you find nothing, and you're exhausted. Because we cannot focus in here and now. And that is mindfulness. Next, please. So, mindfulness is nothing but a tool. And I was mentioning Dr. Shapiro, and one of the things that I learned from her is mindfulness is nothing but a tool called transformation. A transformation between thinking in the past and thinking in the future. Just transform your past and your future into your now. Think about your now. How do we do that? Next, please. So in order to do that, life is teaching us a lesson. But we are deaf. We do not pay attention to this. And it's interesting how life is full of mindfulness. Yes, we can meditate. Yes, we can do many things. But, something that may calm most people, unless you have a phobia, hugs. Being with others. If COVID taught us something, was that we need to have company. We were desperate for company. This is a pleasure now. Having and being together in person, for me, is a blessing. So just being here is a blessing already. But all of this, for some people can be cooking. It's not universal. If I enjoy cooking, that is, and that is what I keep me peace. That's my vitamin. Why? Because I am focused in that cooking. How much salt, how much this, I'm following the recipe, but I am focused. And I don't care what else is happening. I'm focusing here and now. So of course, there are many other recommendations. Be an optimist, have hope. What is the hardest? Accept yourself. We are always criticizing ourselves. It's hard to accept, this is me. This is the way I am, okay? So what can I do to manage that? Next, please. So Walt Disney used to say, hey, let's quit talking and begin doing. So we have to do something about it, right? So next, please. We need to lower our cortisol. And how do we do that? If cortisol is up, the blood goes to the key points, even if we don't need it. Goes to the guts, goes to the heart, goes to the lungs, but then do not go to things like your skin. And one of the things that happens when you're stressed out is you lose your hair. Because to survive, you don't need your hair. So less blood goes there. Right? What happened to your skin? Less blood goes there, so it becomes dry, itchy. When people are stressed out, what do we start doing? We have all kinds of allergies. And it's exacerbated because of the cortisol and because of the stress. So next, please. So there are the hormones here generate everything in there. I don't want you to spend your time is not the focus, but I told you that I will mention a couple of hormones in there. That is how it happens. But the why is what we can control. And we can control that just by focusing in now. Not the past, not the future. Why is that recommendation? If you want, all these articles are in the site. The citation is there. You just log in, download that, and all the explanation, the scientific basis of what I said are in there. Next, please. So our mind wanders 47% of the time. We're wondering because that was survival. If we focus too much, a predator may come. So we have to wonder. But at the same time, 90% of what we worry about never happens. So why do we worry so much? So we focus in the past, in the future, but we are wasting almost 50% of our brain capacity by not paying attention. What can we do? Next, please. Okay, so mainly is what we practice grows stronger. We know that. For centuries, we know that. So by working and the way we approach sometimes our work every day, we practice judgment. Oh, look, I don't like this person. Yes, I like this person. Your judgment. You're judgmental, judging all the time. That's what we practice. Or impatience, frustration. Many of us become masters of frustration. We focus, oh, this frustrates me. Instead of what does not, what makes me happy, we are always finding and looking for a reason to be frustrated. And that's sad. But that is our reality. So the more frequent you are frustrated, the more frustrated you are going to become, because that's what you're practicing. Mindfulness is focus in your now. That way, you don't have to focus and practice your frustration. Okay? If I'm not going to teach you about meditation, but I strongly recommend you to go and learn to meditate 5 minutes 3 times a day. That's quite easy. Next, please. So, just to close, I want to do a quick exercise. And just talk to your neighbors you can. I see probably there are a couple that are 3, so just converse among the 3 of you. So I'm going to give you 1 or 2 minutes to do the following. Just identify 3 priorities today in your life, okay? Write them down. 1 minute, please. Go ahead. 3 priorities, 3 things that you think that you would like to prioritize in your life, or are things that you consider that are priorities. Go ahead and write them down. And it's a commitment, because I want you to write them down. You don't have to share them, but you have to write them down. Because this conversation is with you. 3 priorities. Okay, thank you. Now, think about today. How much attention and how much of a priority really is in your life. That's what you consider a priority. But how much of your attention are you dedicating to this particular priority? 10 or 5 is a random number. 10 is the maximum. 1 is very low. So put a number. Okay, now we are going to do the last part, and the other person doesn't have to have any idea of what are you talking about, but you're going to listen and you're going to talk, okay? So this is what you're going to do with the person that is next to you. You are not going to ask anything, you're just going to listen, and what this other person is going to tell you, and then you switch, is one simple thing that you're going to do to move that number, whatever number you gave to those priorities, okay? Out of the 3, choose 1. Okay. Go ahead, choose 1. Okay, now, 20 seconds, what are you going to do to move that priority up in the list? So, you're going to talk to the other person. There's a reason for this. It's a braining, it's a brain activity, generate a connection, because what you talk is what you become. What you practice becomes stronger, okay? So 30 seconds, 1, and then we switch. Start. Go ahead. 1. Okay. Please switch if you haven't. Listen, no comments, just listen. Okay. That's it. I know that now you want to keep talking. That's the idea. But do it with yourself, and you need to talk to you. You need to focus and here and now. That's mindfulness. Use any tool and just take the printouts of the slides and any of those things in there, practice them. Thank you very much. Have a nice evening.
Are there any questions for Dr. Solano?
Okay. Any questions? I used all my time, so I was afraid of asking questions. This is just dipping your toe, as in the water, but that was the idea, to generate motivation. By any means, this is a lecture about mindfulness, but is asking the key questions. Focus on yourself. Yes, ma'am.
So, as I am aging beautifully, I'm running into a lot of stuff that I didn't deal with when I was younger. This inflammation.
Yes.
It's a big word in this age that I'm approaching. And I'm beginning to feel like I'm picking up more inflammation throughout some parts of this wonderful body. I just wondered, sometimes you got all these crazy commercials on TV advertising Omega XL, Nuriva, Nuvira, or whatever it is. To avoid medication, how do you work on that inflammation?
Okay, that's a tricky question, but I'm going to answer that in my best possible way. Number one is I'm going to refer to research. Research shows that probably the only thing that works overall is omega-3, as a substance that may prevent this. Second, inflammation has been there forever. What happens is with aging, you tolerate less inflammation, so you feel the consequences more. It doesn't mean that they have not been there. Your body responds in a different way. The third is something that you have to be careful, is that with aging, there are some vitamins that come down, especially vitamin D. D for David. Okay, excuse my English and accent. But so there are many things that we have to check, and we know that we need to check the levels. They were not important 20 years ago. Now we know that, yeah, we need to check vitamin D. We need to check some things in there. But overall, for mindfulness, omega-3 works. Yeah, and there are many correlations, but please read that. Okay. Thank you.
All right. Thank you so much, Dr. Solano. All right. Welcome back, everyone. I hope you found the breakout sessions encouraging, enlightening, maybe even invigorating, especially after all the bad news from this morning. The last session of the day brings us Justin Gus, who's the Director of Community Health at El Centro. Justin has been working with Spanish-speaking communities for several years to increase participation in health programs and public benefits. Please welcome Justin Gus.
Hello, hello. So I'm Justin, I'm with El Centro, and I have the pleasure of being the last speaker of today. So don't go nowhere, stick around, we'll power through. Next slide, please. So a little bit about what I'll be talking today is really kind of understanding why as community health workers, we should be connecting our clients to public benefits and resources. Kind of looking at some of the barriers, and I kind of moved my slides around a little bit just to focus a little more time in that section because I thought it was more relevant to the work we all do. And then also to talk about approaches that we take to screen our clients for different services that they might be eligible for. And then also the importance of staying informed and connected as a community health worker. And then lastly, I'll kind of share a little bit about a program that we have at El Centro to help people with those enrollment needs. Next slide. So just a little bit about me. I started off as a community health worker out of college. My profession is in social work, and I actually started at the Casey Care Clinic as a diabetes health promoter. After that, I also was part of that first cohort of students with Metropolitan Community College of Community Health Workers. Hey, Florence. And then I started at El Centro as a health navigator, which is kind of a different type of community health work. We also have enrollment specialists, and we have our health navigation staff who are here with me today. And also we have a pretty robust Promotores de Salud program at El Centro. Next slide. So just to get a feel of who's in the room, I'm gonna call these out, and if that's you, please wave, let your neighbors know. But do we have any, let's see, start off with any case managers? People who do case management services? No, not so much. How about any promotores de salud or health promoters? Any educators? Enrollment specialists or marketplace navigators? I'll throw that out there. There we go. How about patient navigators or health navigators? Any care connectors, or coordinators, I should say. How about community health workers? All right, so our titles are many. There's a lot of different types of work that have evolved over the years. But with that, the most important thing to know, next slide, is it's all about connection. So oftentimes community health workers are known as that bridge between the community and the healthcare provider. Other times they're kind of the coordinators who are in the middle of all the different aspects of care. Others are just kind of directors to steer people to services and resources that they need. But the most important kind of takeaway is that connection piece. And in particular, connecting people to resources that they might have just be finding out from you for the first time. Next slide. So just a few reasons why it's important to consider how you're connecting your clients or your patients to resources or public benefits. One, we know that it impacts their health. If they have health insurance, they're going to have better access to healthcare services. They're going to be able to access things that they need outside of the healthcare realm, such as food and other like housing services. It's also part of our role as a community health worker, navigator, enroller, can make those connections for people too. Actually, on the Missouri, I was looking up, and it's actually one of those core competencies of a community health worker, is to be able to provide those resources and that education about different public benefits that are available to people and helping connect them to that. And then the third reason is you really can't do it alone. If you're out there trying to do everything under the sun for your client or for your patient, it's going to be really hard. You're going to become frustrated, and you really need to be able to make those connections to appropriate services. Next slide. And one of the other things is that some of these benefits that are out there now are longer and more sustained than just a simple Band-Aid. If you have a client experiencing food insecurity, for example, sure, you might know of a local church or a pantry that provides food services, but if you're able to enroll them into SNAP, which would help all of their family they would be able to sustain that need for a longer term. It's not just a quick Band-Aid or a quick fix, although those are needed sometimes, like while you're waiting to be approved or denied for SNAP. But we know that those longer-term services create more stable households for patients. And besides just looking at that health access lens, we also kind of know that directing people to public benefits can help them financially. And if there's better income in the home, there's better health outcomes in the home. There's also other programs that provide work supports and other needs that sometimes we don't consider when we're talking to the patient or the client about their health. But it is important to note that every state is different. After hearing Juan's talk about Medicaid expansion in Missouri, Kansas has not expanded Medicaid. And I'm like, it's not too bad. It's not too bad right now for Kansas, but we know it's definitely needed. And when that happens, we're going to be there to help people along the way. So what are some other of the public benefits? Just start shouting them out. What are things that you help your clients find, enroll in, apply for? What are some of those resources? Utility assistance, that's a big one, especially with COVID. There were a lot of programs that came out federally to help provide that assistance. What else? Transportation services. Again, COVID, both a blessing and a curse, has made transportation programs a lot more available for people. What else? Housing. Anything else? Medicaid. Rent assistance. Yeah, there's a lot. Next slide. So here's a few that I listed. And these are things that my staff and my program help out with or have helped out with over the years. But you can see on there, there's beyond just health insurance, there's a lot of types of health insurance. Thinking of food security, Meals on Wheels programs for those who might be homebound and not able to go out and get food assistance. Taxes, we all hate them. Clients hate them more, but they're important to do and to help people get those tax credits if they're eligible for those. Dental coverage, financial assistance applications for hospitals, helping people sign up for the census every 10 years when it happens. There's a lot of different programs to navigate, and it can be kind of confusing at times, but they're all important to think about when working with your client beyond just the scope of healthcare. Next slide. So you don't have to become an expert or a master in all of those services. I certainly am not. Some services I tried over the years, became a SHIC counselor to be able to enroll clients in Medicare, hated it, and only did it for like a couple of years and then dropped out. It's not my forte, it's not my expertise, but there are resources out there that can help clients with that. So it's important to be aware of what those resources are and how you can assist your client at that time. You also might not be able to help a client directly enroll into services, but you should at least kind of know the ins and outs of the program or what the service requirements are. Clients oftentimes get frustrated if you're trying to make a referral to somewhere and then it turns out they weren't eligible to begin with. They're going to kind of be upset at that agency you referred them to. They're going to be upset with you and just kind of frustrated in their situation. And then you also might not know where to turn to right away, but that's why it's important to build your resource network. It's important to have kind of those people that you know who are the experts in those fields to be able to make those connections and kind of have a warm handoff rather than just a number to call. Next slide. So let's say you found a service your client needs. So Medicaid, for example. Now what? Well, you have a few options. You can either help them enroll or apply for them directly. It really depends on your role as a community health worker and also what your agency will allow you to do. You can refer or connect them to an agency that can provide that service to them. But I think the most important thing is to help them break through those barriers. And we're going to spend some time kind of looking at what some of the common barriers are. Just to give you guys kind of a heads up, like at El Centro, most of our clients are Spanish speaking. We do work with a lot of immigrant households or mixed status households. And there are a lot of barriers very specific to the population that we serve, but there are also barriers that are kind of common across helping clients as a whole. So next slide. So the first barrier I'm going to talk about is, I don't like to call it a language barrier because that kind of has a negative feel or kind of a deficit, like the client doesn't know English, that's a barrier. Rather, it's that there's a lack of resources that are bilingual or that can meet them and their language needs. There's a lack of services that are culturally and linguistically appropriate. So Kansas City, we're still growing. We don't have a lot of agencies that are dual language or bilingual or are able to help clients with every single language out there. But as we see states grow, see populations grow, we know that changes over time. You look at places like California where it is a bigger melting pot, but you have tons of nonprofits in all different languages and different cultures there to help people. So we're still getting there. So language is definitely a huge barrier that we see. And to help with that, there's a couple solutions. I don't like to just talk about the problems without presenting solutions. Some of those solutions could be helping interpret or translate documents for your client. That might be over the phone, might be in person if you're helping them fill out an enrollment form, but being able to use your skill, again, it depends on your agency. Some have a higher standards or a certification practice. Others, you're pretty much free to help how you can help. Using language lines when they're available. Not everyone has them, especially at most of the clinics. They're fortunate enough to have language line access. But I'm also thinking of those 1-800 numbers, or for an example, if you're trying to send someone to CanCare, Medicaid on the Kansas side, they do have services in Spanish. Press 2 to get a Spanish-speaking representative. But it's important to try that number out before just referring the client because oftentimes it's not as great as it seems. They still might pick up the call in English, and that's important to tell your client to ask for an interpreter, or that they have the right to ask for an interpreter when they call. So kind of giving the insight to clients ahead of time is a good way to empower them. And I also like to call with the client once, especially if they're really nervous, so that way they see it's not that hard of a process. We press 2, we wait, they answered in English, whoop, we need a Spanish-speaking representative or an interpreter. We wait a little longer, and then we get through. Once they see that the process really isn't that bad, it's a little easier for them to do on their own in the future. Although you probably will have a client who, no matter what happens or how great the language services are, they're still going to want your help. And then lastly, you can also advocate for change. So especially if it's within your own organization, trying to advocate for language lines or to make services more accessible to clients, clinic forms, there's a lot that can be done pretty easily and at pretty low cost, just to start to make it easier for the clients that you're working with. Next slide. So documentation. This is probably one of the worst areas or hardest areas to navigate sometimes. You've got a great service out there, you know what they need. They need to provide a 30-day supply of income, but they can't print off their pay stubs. Or they don't get pay stubs, they get paid cash. Or they work for their own selves, and therefore they don't have any pay stubs that they can provide. So that's just one of the examples of documents that might be hard. It was mentioned earlier, having a mailing address can be a really big barrier or challenge for some clients. There's also that documentation as far as legal or immigration status. So some possible solutions there are to always try to help the client get those documents when you can. We are pretty hands-on at El Centro, so sometimes let's say, oh, well, let's look on your phone together, log into your HR portal and see if we can't email one of your pay stubs to us to print out. Sometimes it'll work in the form of a screenshot and they'll text it to us and we print it off that way. There's a lot of ways that you can kind of help facilitate the process rather than leaving your client hanging and not really knowing what they should do with this documentation requirement. You can also check for alternative options. So there are some programs we've come across where they only want pay stubs. but talking to them about getting a letter from their employer or maybe a notarized letter from their employer, they might make that exception and take that letter rather than the pay stubs. And also refer to help to get documents needed before applying for the service. So if you know right away that a service you're enrolling a client in is going to require a birth certificate and they don't have one, you gotta start there with that service. You have to help them get that birth certificate first before applying and kind of coming across this roadblock later on. And then lastly, just kind of getting creative. Again, talking to people about what they can provide. Sometimes we write our own kind of advocacy letters when applying for financial assistance at hospitals. And rather than make the patient go through this kind of back and forth process with the hospital, those advocacy letters might work. They'll know that we're working with the client. They'll know what documents they're not able to provide and what documents they can. And oftentimes that might be a good solution to go with. Next slide. Deadlines and due dates. So this one's hard too, especially for things like the marketplace. We know that the open enrollment period is very short. It only lasts from November 1st to December 15th. Some years that gets extended, some years it doesn't. And so if clients miss that opportunity to apply or to enroll, they're kind of stuck for the rest of the year unless they have a special enrollment period. So some tips with that, and really also the follow-up after you submit an application for Medicaid, for example, they might get a letter in the mail that says, we need, more proof of income, or we missed one of your pay stubs, and they give a very tight deadline of 10 days to reply. Well, by the time the client has gotten that letter in the mail, now they have 5 days to apply. And by the time they get an appointment with you, they might have 1 day to apply and to get that documentation in. So some of the solutions there would be to check in with your client often. If you know the turnaround time is going to be 2 to 3 weeks, maybe schedule an appointment in 2 weeks to follow up with your client and see if they've gotten any documentation in the mail. You can also put it on your calendar or schedule it as a follow-up appointment. And then the other thing you can do in some cases is list yourself as a facilitator on the application or an advocate. Sometimes they're worded different depending on what you're applying for, but that gives you a way of getting direct communication or access on the client's behalf, and you can kind of really advocate, especially for those clients that have difficulty calling or trying to ask those questions on their own. It really allows you to be more hands-on, but with their consent. Next slide. So other things, these are a little harder barriers to navigate through because they're often out of our control. So lack of funding. There's a program out there for transportation, great, but the funding ran out after 2 months. There are wait lists, Section 8 housing. You can maybe get an opening to get an application in, but the process is still going to probably take 2 to 3 years depending on what county your client lives in. And then also excluding eligibility requirements. So if a program is open but excludes people who might be undocumented, that could be a barrier for the clients that you're working with. Some of the possible solutions there are to try to advocate and become more involved around the issue. We've kind of seen that with some of the programs that came out with COVID. For example, CARA on the Kansas side, that's at Kansas Kansas, that's the Renters Assistance Program in the Kansas side. And initially they were like, oh yeah, anybody can apply. COVID's affected everybody. But then through their application portal, they required that a social be entered or an I-10 be entered. And we were like, that's not what you guys told us when this program first came out. So advocating and letting them know the households that were really in need, the clients that were having issues, they were able to finally make an exception and, okay, we'll put in any number as long as it corresponds to some type of photo ID they have, like a passport or a consulate card. So not giving up, that really, really helped, and trying to advocate and make that assistance available for everyone in the community. You can look for alternative programs too. So if the family is not eligible for SNAP, you do know that there are food pantries out there that don't have those requirements. So that might be the best alternative program for that need. And also staying up to date on services and being knowledgeable about those changes can really help. I knew the expansion had happened in Missouri with Medicaid. I just didn't know all of the troubling details that I learned this morning. So staying in touch with what's going on will help me be able to navigate my clients better if they're needing coverage here in Missouri. Next slide. So kind of the last barrier I will talk about is you've signed a client up for a service, that's great, but do they know how to use it? We've kind of went through that in our own program. We were able to enroll people into dental coverage through a partnership with United Way and Delta Dental of Kansas. Sorry, it's not on the Missouri side. But in enrolling people into that program, now we're at year 2, and we're able to renew people into coverage. And we found out that a good percentage or portion of the clients we enrolled in coverage never actually used their dental benefit. So we were kind of shocked and like, oh, what's happening there? Turned out a lot of them either didn't get their card or they got the card, but they weren't able to find a dentist. They didn't know who took the coverage. So there were a lot of other little barriers that came about. And to make that service even stronger, now we're trying to add that follow-up component to there and to be able to follow up with clients and make sure they're actually utilizing the benefit they're signing up for. So some solutions to that is if you don't know about the benefit yourself, learn together with your client. A lot of people, especially younger people, don't have that much experience with health insurance, filing claims, disputes, all of that. You kind of learn as you go and you have to navigate yourself through that own process. And you can use that information to help your clients in the future. Staying informed, being aware of all the changes that are going on. You can also, if you have other clients that have been through a process already, you can use kind of their experience in talking to other clients. Like I personally have never had food stamps and I've never seen how it works, but I know a lot about it from hearing from other clients who have utilized that benefit, the stores they can go to, what foods they can buy with it. There's a lot that you can learn from your client and relate that experience in helping others. Also, you can look for educational videos, handouts. There's a lot, especially colleges. They produce a lot of materials in the social work departments and other areas. So you don't have to recreate the wheel. There's a lot of stuff that's already out there online about a lot of different programs. You just kind of have to dig around. And then also sharing your own experiences or common experiences, as I mentioned. Next slide. So that was a lot of benefits on that prior screen that was listed. How do you know which ones to sign clients up for, what they're interested in, how do you assess? You know, you really want to provide the best service to your client, but how do you get started with that? So this is going to depend on your organization and your role. Like health promoters, for example, our health promoters at El Centro are mostly focused on food and nutrition. So they become very trained. They know how to talk to people about dieting and healthy eating, how to read food labels, but they don't know a lot about other benefits or services. So that's kind of where it depends on your role in your organization. It also depends on what the client wants to do. We have had a lot of clients that, you know, we're like, the service would be really great for you. You're going to save some money on your bills every month. You can get into great care, and they still don't want to apply. And they have the right to just say, no, they're not interested. And then also, if you get into a pattern or a routine way of how you screen or assess clients, it's going to make the process easier. Next slide. So here are some tips, some helpful tips in screening clients. So it's also important that you think about meeting the client's initial need they're coming to talk to you about. If I'm coming in to get signed up for coverage and Medicaid, but you're talking to me about food stamps and childcare and other services, and I don't feel that you're listening to my need about Medicaid and my frustration with that, I'm likely not going to come back or follow up with you because I'm like, they didn't listen to me. So it's very important that you address that initial need. Maybe you do the application, and as you're filling out the application, you talk about other services that they might qualify for. Number two, using the information you already have. So how many people have some type of intake or assessment that they do when they first meet with a client? There's a lot of information on those intakes, dates of birth, how many people are in the household, income. So you have a lot of information already, and you might be able to know, based on that information, what other services they might need. So date of birth, for example. If I have a client who's 64, that's a red flag that next year they're going to be eligible for Medicare, and they're probably going to need some help with that transition. Maybe they are 40, and they just turned 40. Now I know that they might qualify for early detection services in Kansas and can get a mammogram. And I might want to talk about that program with them. So there's a lot of information that we gather on those intakes and through that assessment process, but we don't always do stuff with that information when it's right there. 3, you can make a screening tool or have some kind of checklist. The graphic is an example of that. We posted these at our desks. So it's kind of like, if I don't ask you about these services, ask me. And trying to remind the client, like, you might be eligible for these things, and we can help you enroll in those services. You can also create a shorter list of services, like I just mentioned, to have out for your clients to view and see. And the other thing is, you don't have to do it all at the time of that appointment. That's something that frustrates staff sometimes. It's like, wow, I just met with this lady, now she needs help with Medicaid, SNAP, all these other benefits. How am I going to get it all done before my next client shows up? You don't have to do it all right away. Focus on the primary need, and then you can schedule those other services later on, or have them fill out the parts of those applications that need to be filled out right away, and go back and finish the rest later with the information you gathered in your intake. There's a lot of possibilities to think about. Next. Just some things to think about when screening or assessing clients. You really do want to be sensitive and respectful of their situation. At El Centro, we don't ask immigration status. It's not on our intake forms. It's not something we just flat out ask people because we don't want to lose that trust that they have in our organization. Rather, we kind of indirectly ask those questions. Or I might say, to be eligible for CAN Care, you have to be a citizen or a permanent resident of 5 years or have some other type of status. Do you think you qualify? If they say no, end the conversation. If they say yes, then we can go on with the application process. We also never sign clients up for stuff that they don't want to sign up in, even though it might help them. We've had some of those stories with insurance lately, just being stuck on a bad insurance plan. You should really, get off of that insurance plan. It's not covering anything. They're going to take out another $350 next month. But the client's really afraid that if they're going to lose their coverage and have no coverage, so it's better to wait. If the client isn't sure, you can always provide those educational materials or more information so that way they can make an informed decision. And then also ask things that make sense when you're filling out applications. For example, if you have a client who's unbanked, they have no bank accounts, they're probably not going to have a retirement fund. They're probably not going to have a pension. They're probably not going to have an inheritance that they gave away in the past 5 years. These are all questions on the Medicaid application. They're not going to have a trust or an annuity. So why spend the time asking every single question when it's not going to apply to them? And then again, you can also list yourself as a facilitator to help make that assessment process easier. Especially when trying to help clients apply for services over the phone. Next slide. So kind of switching gears, why it's important to stay connected as a CHW. The more you know, the better you're going to be able to help your clients. I think that's why we're all here today, is to be connected and to also know about changes and services that are out there. It's also a part of our role as a community health worker. Also, resources and eligibility change all the time, especially with the pandemic. Programs have been extended, programs were renamed. It was CARES, and now it's CARA. They have to be COVID impacted somehow. Now they don't, they just have to have a financial impact. There's a lot of changes that always happen, especially at the federal or state level, that then impact the programs we're able to enroll people in. So it's very important to be in the know and be up to date about those programs. Also, again, as I mentioned earlier, you can't do it alone. Care coordination is a tricky process, especially when trying to enroll people into services and navigate them. And barriers might take more than just one person. I had a client with CanCare whose claim got denied, and then they were stuck with like a $20,000 bill for a procedure their daughter had. Took a phone call to CanCare, and it took a phone call to the CanCare plan, and then it took a phone call to the supervisor and a lot of follow-up, but we were able to finally get that bill resolved, and the client wasn't stuck with that claim that was unpaid. So sometimes you just have to stick to it and keep going. Next slide. Also, knowledge is power, and the more you can pass on to your client, the better. They're going to have a better experience with you, but they're also going to be able to use that knowledge and pass it on to family members and friends. A lot of the clients we see at El Centro, they hear about us from word of mouth, but that also works with the knowledge that we pass on. So, hey, did you know you could sign up for this program? It really helped me. It could help you. The more information you're able to give to clients, the better off they're going to be. Also, having a resource list is important, but more importantly, keeping those connections up to date. So if you know someone you can call at CanCare who's going to treat your clients a lot better than just calling the 1-800 number, keep that number and keep that contact because it's going to help you out a lot better. You also want to be involved in coalitions when and where possible. It's very important to kind of be connected in that sense because you get a lot of information from attending coalition meetings and also joining email lists. I know we get a lot of emails, and sometimes it can be overwhelming, but I'd rather have something in an email and know about a change that happened in a program than not know at all, and then later have frustration for my client because I gave them bad information. And then also just don't reinvent the wheel. There are a lot of programs out there that help with enrollment. There are places that are specialized in certain types of programs and care. So rather than trying to figure out how to do that whole process yourself, if you're connected with others, you'll be able to refer them to those resources that you know are really going to get them taken care of. Next slide. So just a little bit about El Centro, and I'll talk about our program to wrap up. We are a welcoming center for Latino immigrants and families. We have a 45-year history of serving Wyandotte and Johnson counties in Kansas. We do provide wraparound services, so we have our health navigation program, our promotoras de salud. We also have an academy for children. It's a dual language preschool over in Argentine, Kansas, that teaches in both English and Spanish and gets kids kindergarten ready. We also have an advocacy and community engagement program, which helps with voter registration, know your rights as an immigrant, know your rights as a tenant, lots of different advocacy work there. And then we also have our economic empowerment program, which provides health literacy, financial literacy. It's our emergency assistance program for rent and utilities. And we also help with different classes like home buyers education in Spanish, how to open a bank account in Spanish, all of that information. Next slide. So we started back a few years ago, started a project that we call Inscríbase. That means get enrolled. And our Inscríbase project is kind of a pairing of our promotoras de salud, which are really our outreach arm of El Centro, with our health navigation program and our enrollment specialists. So our promotoras go out and talk about different programs. One of the programs we talk a lot about is Medicaid. So the benefits of having Medicaid. There are a lot of Latino households that might be mixed status and they don't know they can apply for Medicaid for their children. And that has been a huge barrier in keeping people out of care. So our promotoras go out, they talk about it, they know the basics about Medicaid, what it covers, who's eligible, how it works, and then they're able to refer clients that are interested to come meet with our health navigators and our enrollment specialists who provide the enrollment assistance. So it's kind of a combination of those different programs. We also focus a lot on SNAP and also have been talking about the CARE program a lot as well. And then we both kind of also use in-person meetings. We also have weekly classes our promotoras do. They focus on health and nutrition, but in those classes they talk about Medicaid benefits, other benefits that people need to be aware of, the public health emergency ending, and people needing to renew their coverage coming up. They provide a lot of that information to people so that way we can connect with them later on. Next slide. So it was kind of a response to the mixed status households that we were serving. There was also a lot of fear working with our immigrant population around public charge because they tried to change it a few years back. Now it's back to normal. But when that change happened, we saw like a drastic decrease of families enrolling in benefits like SNAP and Medicaid. People just kind of assume that the public charge change that happened is still happening today. And so trying to combat that fear with the facts and really trying to reach our population during the pandemic as well. We started doing a lot of online social media. There's an example there on the screen of one of our Medicaid enrollees sharing a brief snippet of her story as to why she enrolled into Medicaid for her daughter. And providing that information when people see each other or see their community represented online, they're like, hey, that's me. I have a daughter too. I don't have a pediatrician or coverage for her. I need to call El Centro and get her enrolled. So it's kind of an educational campaign mixed in with our enrollment assistance as well. And next slide. So kind of finishing a little early, but I'll open it up for questions. A lot of our stuff on Facebook is in English and Spanish, but pretty proud of the work that we do. So if you want to take a look, you can look at our Facebook page. That's really where we update and provide a lot of information. There was a question about materials, about the ending of the public health emergency and people needing to enroll in or change their address or update their address with Medicaid. We've created a series of PSA videos about that in Spanish with English subtitles. So we've only posted one on Facebook because we started those videos back in January and it just kept getting extended and extended. So we're kind of waiting until it really happens to put them all out there. But there's a lot of examples that other people can look at and learn from, especially in trying to make your information available in more than one language. So now I'll open it up for any questions.
Are there any questions for Justin?
We do. We're not experts on Missouri services, but we do get a lot of Latino families from Jackson County in particular that call us for help. So we'll always try to help them figure out their situation. But it's a learning curve for us in some ways to try to get them navigating Missouri services, especially with the expansion going on.
Anyone else?
Going once, going twice.
All right.
About the what, I'm sorry?
The dental services?
So that's a service, dental services. That is a program that we started a couple years back. It's a partnership with United Way of Greater Kansas City and Delta Dental of Kansas. So we're one of a few organizations that can enroll people into that benefit. They do have to be a resident of certain counties in Kansas and meet the income guidelines of 250% or below. But really it's a program designed for people who aren't offered dental coverage at their job. So someone in the home does have to be working, just not offered dental benefits. We're able to sign them up, it's free. There's no monthly costs. It's just a small deductible that they would pay when they go to the dentist. And it covers up to $3,000 worth of benefits per individual in the family. So it's really good. Yep. Awesome. Well, thank you so much for your time.
right, so that wraps up our presentations for today. Thank you everyone for joining us today in person and for our virtual audience. We had over 200 people on the virtual audience today, so we had a pretty big crowd out there. I just want to take a minute to thank the folks on the planning committee who helped put all this together. We have Ray Hutchison from HRSA, who's doing all of our tech support back there, Trevis Smith from Casey Care, Anaid Ruiz from MARC, Dr. Manuel Solano from Samuel Rodgers Health Center, and Simone Taylor from OASH. So thank you to all of those folks who helped keep all of these things going and doing all of the pieces in the background. And this is the QR code for the evaluation. So if you would like a certificate or CEUs, you have to do the evaluation. You will also get an email in the next week or so with the evaluation link and QR code. So you can do the evaluation now by scanning the QR code, or you can go to tinyurl.com/normal22survey to do the evaluation. So please participate in that if you would like a certificate. That is all we have for today. We really want to thank everyone for participating and coming out. It's so great to see everyone in person. And if you have any specific feedback for any of the speakers or questions, feel free to reach out to them directly. A lot of them provided their email information during the presentation. So thanks again, everyone. Ray, did you have anything you wanted to add?
Hi, I'm Ray Hutchison with the Health Resources and Services Administration's Office of Intergovernmental and External Affairs. I just wanted to thank our speakers for their fabulous presentations today. I hope that everyone found them informative and helpful. I know that I sure learned a lot. And just to echo what Ashley said to all the folks on the planning committee, thank you so much for all of your hard work. HRSA greatly appreciates your support and partnership, and hope that we can put on future events like this again in the future for community health workers. Florence said something this morning that really resonated with me. She said something, community health workers are not the resource, they're the bridge, they're the connectors. So in my role at HRSA, that is what I am. I do not pretend to be an expert in all of the 90+ programs that HRSA has to support communities, including community health workers. I'm that bridge, I'm that connector. And HRSA has a wide variety of resources and programs that are available to support communities, including community health workers. We actually have a funding opportunity that's open right now. It's the Community Health Worker Training Program. Applications are being accepted through June 14th. And if you're interested, please email me in the next few days. You'll receive a couple follow-up emails with a link to the presentations, the evaluation, as well as the recording of today's summit once it's available. So if you have a question about that notice of funding opportunity or anything related to HRSA programs, please reach out. Want to be that connector and resource for you. And thank you again for your time today. We really appreciate all of you.
Yeah, thank you. And also, the certificates will go out by the end of the month. So you have until then to get those evaluations completed. Thank you, everybody, and have a good rest of your day.